welcome to the Health and Wellbeing Board. Before we start these proceedings, can I bring your attention to some housekeeping matters? There is no expected fire alarm testing today. Therefore, if the alarm sounds, please follow the fire and emergency procedure that's applicable for the council house, which is basically out the nearest door and then over the front of the council house. The meeting will be broadcast live to the internet and will be capable of subsequent repeat viewings by entering the Warspite room, and during the course of the meeting, committee members are consenting to being filmed and to the use of those recordings for webcasting. Please can I ask that you speak clearly and directly into your microphone when addressing the meeting so that the online participants and the public can hear, and that it is switched off when you are not using it. Patrick, you'd like to make sure that Tanya is okay, thank you. And your mobile devices are turned to silent. She quickly checks. So I'd like to go around the room and everybody introduce themselves.
Councillor Andy Glugger, Vice Chair.
I'm Mary Aspinall, Chair.
Steve Madden, Director of Public Health.
Elliot Werngle, Democratic Advisor.
Rob Smith, Chief Exec of Improving Lives Plymouth and Chair of the Wellbeing Hubs.
Gary Walbridge, Strategic Director for Adults, Health and Communities.
Michael Whitcomb, Deputy Chief Operating Officer at UHP.
Morning everyone, I'm Rachel O'Connor, Director for Integrated Care Partnerships and Strategy at UHP.
I'm Councillor Jemima Lang, I'm Deputy Leader of Plymouth City Council and I have the Children's Culture and Comms portfolios.
Morning all, Councillor Patrick Nicholson, Leader of the Independents.
Morning everyone, I'm Tanya Payne from Healthwatch Plymouth, standing in for Tony Gravitt.
Online, Chris.
Morning, I'm Chris Morley, Locality Director of Plymouth and NHS Devon ICB.
Peter.
Morning everybody, Peter Collins, Chief Medical Officer at Devon ICB.
Louise.
Morning, Louise Ford, Head of Commissioning, Adults and Homelessness Integrated Commissioning, Plymouth City Council.
Thank you. Ian.
Yeah, morning everybody. Ian Lightley, Chief Operating Officer at Live Well South West, stepping in for Michelle Thomas, CEO.
Melissa.
Morning everyone, Melissa Redmayne. I'm the Pharmacy, Optometry and Dental Commissioner at NHS Devon.
And last but not least, David.
Morning everyone, David Haley at DCS in Plymouth.
Thank you folks. I'd like to ask the Democratic Advisor if there are any apologies for absence.
Thank you, Chair. We've received apologies from Tony Gravitt from Healthwatch, Tanya Payne is deputising today. Apologies from Rob Fern, University of Plymouth. Laura Alexander will join us online. Apologies from Michelle Thomas, Live Well South West. Ian Lightley joins us online. Apologies from Karen Pilkington and Matt Garrett.
Thank you very much. Do you members have any declarations of interest? Nope. Right. I don't believe I've got any urgent business, have I? No, that's good. So we can go on to the minutes. Can we confirm the minutes of the meeting held on the 12th of June? I would like to propose that we agree the minutes as a correct record. Do I have a seconder?
Second that, Chair.
Thank you very much. And we'll put that to the vote. Everybody happy? Yeah. Yeah, great stuff. Questions for the members of public? I have none. Which brings us to item 6, which is winter planning. So we've got Chris, Louise and Michael. And no doubt Rachel will say something if she feels it's needed. Before we start that, Michael, can you, I'd like to record our thanks to Jo Beer as the Chief Operating Officer and wish her well in her new post. Jo's always been a very good supporter of scrutiny and of this board, so I think I would like to record that thanks. Thank you. So the purpose of this report is to outline the Plymouth system winter preparation and provide an assurance to the Health and Wellbeing Board. So who's starting it?
Shall I start us off?
Yes,
so I've got the slides that were in the pack. I'll share. Can you see those on the screen?
Yes, we can.
Excellent. That's the first win. Yeah, as you described there, Chair, purpose of the session today is just to update in terms of some of the work that's been undertaken around winter planning. As we do each year, we go through a process of understanding what pressures we anticipate coming through and ensuring that we've got robust plans across the whole system, so health and social care, to make sure that we've got functioning flow and service delivery across the winter period. The slides that we've got to share with you today will start by outlining UHP's winter plan, although it's worth acknowledging that this is a concerted effort across partners, and Ian, equally from a Live Well perspective, his team have contributed to this so that it covers all component parts. We'll then take you through a headline around some of the work that we're doing from a social care perspective as well, and making sure that we've got market resilience moving into the winter period, and also give you some of the headlines around the vaccination programme. But I'll hand over to Michael first of all to take us through the UHP bit.
Thank you, Chris. Thank you, Chair. So for the moving to the first slide is a summary of last year's. Oh, sorry, beg your pardon. Moving to the next one. Thank you. Apologies. So for 24 and 25 winter, we saw bed occupancy rates obviously exceeding the 98%. At any given time, an average of 40 patients remaining in the emergency department awaiting an onward bed, and in our increased 12-hour length of stay, and nearly 20% of our patients suffering that onward delay. Ambulance handovers loss exceeding over 7,500 hours, and that's preventing them from going out into our community and responding to our patients effectively. So there is a real focus this year to collaboratively, as a system, meet the mandate from NHS England on delivering those ambulance handovers within the 30 minutes, improve the Category 2 response times, and reduce 12-hour length of stay within the emergency department, etc., as given from the slide pack. We are committed to this and improving our access delivery for UEC. Moving to the next slide, for winter, we are providing some bed modelling and data analysis that, in a summary, there are key 7 work streams across the system, so including Live Well and Plymouth City Council and our community partners and the Trust. The acute bed gap, if we do nothing, is about 70 to 90 beds lost short within the acute trust, to note. So that is a significant amount of issues for us to deliver the UEC plan. But we do have the one plan strategic objectives, which everybody has signed up to already and in train. So we have a number of work streams already ongoing. Forecasting a 50% delivery, that's a reduction of a minus 39 beds. As the 7 work streams, we're focusing on this element and what additionality we can provide during winter to close that gap. Moving to the next slide. I've noticed there was a typo in that slide, so I do apologise. Obviously, our objectives, as I've spoken about, is to reduce those ambulance handover times, but increasingly we are focusing on our length of stay reduction of around about half a day. By reducing that half a day length of stay reduction, we're looking at closing that bed gap around about 22 beds, if we're able to achieve that. That is our increasing robust plan around our processing, our getting our patients out in a timely fashion, and working with our community partners on delays to palliative care and getting people back into their homes. One of the focuses days away from home, and that is something that we are trying to bring the heart of the patient into that, rather than it being a formal process. So again, some of the other focuses are around maintaining and supporting our elective care demands. We have no reason to shut that down with our plan, so at no point will we deviate from that plan. And our vaccination hub and our moments to get our 5% increase for our staff uptake, and obviously encouraging our patient vaccination programme as well, which is also launched. So if you need your flu jab, please come and see us and we'll happily help you with that. Moving to the next slide, just to give you a summary performance-wise at the moment, because I think it's really important to focus on this. Our 4-hour types, all types performance, that's anybody that enters the emergency department or our urgent treatment centre. The standard we're currently achieving is around about 72%, and that's a 6% improvement from the last year. To note, that's where we are. From an ambulance handover hours lost, this time last year we were seeing over 7.5 hours, 1,000 hours lost. So you can see on the bottom left graph how we are trying to commit ourselves to improving that in a downward trend that we are seeing, and we will maintain that as we go forward. Just moving to the next slide, just very summary. I'm conscious of not talking too much. Our key assumptions is that the flu and COVID season will follow the same patterns to last year. So it's the second week after Christmas, from the data that's been provided. We are expecting that peak demand. In particular, we saw around about 120 beds blocked due to noro, COVID and flu. So we are very, very keen to try and reduce that in particular. Our no criteria to reside, we're going to assume will remain between 10 and 13% within the bed base, although we're working really hard to reduce that. And yeah, at the moment, our ICB winter demand and capacity schemes that Peter Collins and his team are also working on will hopefully deliver an intended benefits of 20-day attendance reduction to the emergency medicine from initial analysis. I will skip over learning from the Southern Hemisphere because I've already provided you that summary. The approach and the mitigations, as I've already stated, are a joint collaborative approach. How the acute hospital is supporting the community teams to prevent the need for our patients, our most vulnerable patients, coming in to the hospital and putting them at further risk. And that is something that we will continue to try and provide, given staffing constraints and how we can support collaboratively. And the vaccination programme, as I've already mentioned, we've launched. We do have a mass vaccination hub within the hospital. We're going to do our hard to reach areas, and that's a focus for us, and committed with our local authority teams and our community teams. And it's really important that we capture everybody, because that was one of the gaps that we saw last year. That's the overall summary that I can provide, and I'm happy to take any questions on that.
Thanks,
Michael.
for that. And then who's going to carry on?
So, Lou, are you going to pick up this social care side? Sorry, I would just slowly, it's a bit of a lag on the system as I skip through the slides, but I think we've got work.
Yeah, no, thanks, Chris. I can do that. So yeah, in terms of social care, our preparations, continue in terms of the run up to the winter period, building on those strengths and those improvements that we've already made across the system, working in collaboration with our partners to ensure that we've got effective flow and we've got the right commission capacity. So we've done a lot of work already in place to support that discharge and community care. So working with Advice Plymouth, so coordinating that support across the system, working with the hospital discharge teams to streamline processes to exit people as quickly as we possibly can into the right care packages, and continuing to support those community pathways with our voluntary sector colleagues. Talked a little bit about infection prevention and control measures, something that we raise through our provider forums on a regular basis. And just making sure as well that our providers in the care sector have got the right business continuity plans in place to support the provision of care during those peak pressures and peak times. So there is some additional work that we're looking at in terms of supporting those winter pressures. So demand and capacity, that's an ongoing piece of work around ensuring that we've got the right capacity in the right place, working very closely with our colleagues in the ICB to ensure that we have the right plans and the right beds and the right care. Data integration, this is a big one for us, just improving the data that we have, the forecasting, the modelling to ensure that we have real-time data and we've got that single version of the truth across the system. Optimisation of our brokerage functions, so really strengthening the work of our brokerage teams just to use better market intelligence and improve the time it takes to source those packages. And finally, we've got the Integrated Commissioning Oversight Group, where we work very closely with colleagues in the ICB and LiveWell, just to oversee the intermediate care activity and just ensure that we've got the right mitigations in place to address any emerging pressures. Thanks, Chris. And then just Yeah, sorry, just in terms of our winter plan actions, as I've said, we've already got some of those in train. So promoting the vaccinations. So again, using some of our community providers, but also earlier this week in our provider forum around care home and dom care, talked very much around vaccination programs, but also the infection prevention and control measures that we've mentioned already. And ongoing engagement with our care homes just to make sure that we've got timely discharge assessments in place, making sure that our carers are supported and where we can assisting unpaid carers during winter pressures, making sure we've got the right support for our care workforce, for our care staff, so building their resilience, making sure we've got the right support for our frontline workers. And finally, as we said already, just ensuring that we've reviewed our demand and capacity plans. So just checking in on the data, making sure that we've modelled the right data so that we've got the right commission capacity to support the needs of the system.
Thanks, Lou.
Thanks, Chris.
So moving on, the other detail that we've included in the pack is in terms of the broader Devon vaccination offer for winter. I know we've picked up components of this as we've gone through in terms of this being one of the fundamental building blocks of our winter plan and ensuring resilience ahead of this winter. So you can see there in terms of the eligible cohorts for this year that our campaigns focus around. In terms of the programme of activity and the campaigns that we've got running across Devon, you can see that is now live. So the programme itself fully went live from the 1st of October, absolute priority being those older adult groups. We aim to have that completed by the end of November. An ongoing programme then that commences in terms of schools as well, with the majority of our vaccinations having been delivered by the 12th of December. However, that campaign, as you can see, is going to continue right through till the end of March so that we can make sure that we've got that opportunity and reaching out to those groups that could most benefit from the vaccinations. A real range in terms of our delivery models that we have, so across our PCNs and GP sites, community pharmacies, the school programme, working alongside, as Michael described, in terms of the work with the acute hospital, our community teams as well, those housebound patients, reaching out to those groups to make sure that they have that access and are supported. Really core component is our offering to our adult care homes, and then also having the vaccination centres in Plymouth and Exeter. There's also a targeted outreach programme for some underserved communities as well to make sure that we build on what positive impact we've seen in previous years, but also ensure that we're maximising the opportunity to ensure that we reach as many as we possibly can. A range there, as I say, in terms of the different offers that we've got that are going through, and a really focused approach in terms of our communications and engagement to those eligible populations. As you can see, there are a raft of public communications targeted interventions as well, really building on what worked well last year and where there might have been gaps, making sure that we've got targeted interventions and actions, as you can see there, to really maximise the uptake. And I think, as we've described, there's a real bringing people together through things like the forum, as Lou mentioned, innovate different approaches, where we've got things like some dom care agencies that are offering toast clinics where they've got space for staff, but actually offering that out to other agencies as well. So a real concerted effort across the system to make sure that we reach all groups. That's the end of the slides. I'll take them down, but happy to take any questions at all around that.
Thank you for that, team. That was great. I suppose one of the things that I feel that I would just like a couple more explanations about is somebody's poorly at home, not too sure what it is, but it's obviously something respiratory as such. The ambulance crew come, they decide they've got to go into hospital. Are we really going to have some training, and then the triaging starts there? Because you're not going to want to put that person in with everybody else, are you? So I'm just wondering how you're getting through to the ambulance service that we need their help.
Yeah, absolutely. Really good question. So there are a number of projects, and I'll let Rachel come in regarding some of the Gateway Hub, but something that we're also encouraging is our hospital ambulance liaison officers. They have been crucial to us being able to reach out to our crews, provide additional education and training of additional areas that we can stream our patients more effectively, where we can place them rather than just the emergency department. And not only that, but also some of the work around actually, do they really need to come in and can we bring the care to them at home? And that's something that Rachel probably can explain more on because that's her work.
So what we've been establishing over the course of the last year is what we're calling our Gateway Hub. It's a single point of access for our practitioners in the community where they have a patient who may be unwell and they seek guidance through a GP and multi-professional MDT service through phoning through. They can do that from scene, so our paramedics can call through to that gateway service, get some advice, and we can, working with our partners in Live Well South West, support people at home. So we might ensure that if they're elderly, they might be part of our virtual ward for frailty. They may have the experience of our urgent care nursing team and our rapid response teams. So we've far strengthened that service from what we had last year, with making sure we've got the right clinical capacity and the work with South West Ambulance Service to make sure that their crews are educated and informed about how they access that service in particular.
Are the signs and symptoms any different with this COVID round than the ones that we've had in the past that we know of?
Might be one for our clinical colleagues. Peter, have we had anything through from the Southern Hemisphere around details on the latest strain?
Thanks, Rachel. Can people hear me okay? Yep. The symptoms of the latest variants of COVID remain almost the same. So the usual flu-like symptoms that people would expect, particularly sore throat, a loss of taste and smell, essentially associated more with COVID than flu. Really, in a way, Chair, the exact symptoms are less important than people seeking help and seeking help in the right place for any winter respiratory illness, but being guided to the level of help that they need and where that help can be best supplied. And I think that the work that Rachel and our locality colleagues are describing is exactly right. So I don't think there are any new or concerning symptoms at this point. Our public health colleagues and Steve may want to come in if he feels differently, but that's certainly my understanding, and certainly nothing coming out of the Southern Hemisphere that would suggest there's anything that we need to change focus on at this point.
Thank you very much. Andy.
Thank you, Chair. Certainly, thank you for the report, and certainly some aspirational positives from that report. Very interested in the work with the acute hospital, and the vaccination programme, I'm sure, is paying dividends, and I've certainly seen some evidence of that in the community. So many thanks for that joined up approach. Where I do have concern, of course, is with the ambulance transfer, the handover. It is wholly unacceptable. Plymouth has not seen the like of this ever. It's getting to the stage now where we're wondering whether people are dying in ambulances because they can't get into hospital. So what I'm looking for is more detail on how that's going to be addressed. And moreover, can you give the board an assurance today that if somebody who requires acute medical help, who's lying in the back of an ambulance, will receive the same level in the back of the ambulance as in the ER? Thank you.
Yeah, certainly. So that is our main focus, and certainly something that we're all focused on from a risk perspective. Where there is the surgeon we're not able to offload in a timely fashion, we have the clinicians that are providing the robust support to ensure that the care is being delivered and that's not delayed at any stage. At the point that the ambulance arrives on our site, we take ownership and accountability to look after that patient. In particular, we have our HALO team, we have the rapid and assessment triage nursing team, and also our senior clinical decision maker that is in that space to provide that response to those patients who are waiting on the ambulance. Ultimately, we do not want them to be held for any length of time, so hence the collaborative approach to prevent that, and we will remain committed, but there will also be some risks to that, which is why we've got those teams in place just in case.
I mean, the critical point is the rapid assessment and treatment that's provided on an equitable basis to all patients, and obviously they're clinically appropriately prioritised in terms of where there is a way to make sure that we can get them into the relevant spaces as soon as possible. But that doesn't stop the care being delivered. What I would also say is we have made significant improvement. by 2/3 improvement in our ambulance waiting times in the last quarter, and remain on plan to deliver our plan for this year. That doesn't mean to say that any delay we take really, really personally. Actually, this is somebody's loved one foremost. These are people of our community that we want to make sure that is a reduced time as far as possible. So we welcome this committee continuing to hold us to account, as does scrutiny. But I would say there's been demonstrable progress in the work of our UTC, which we'll talk about a bit later, and further things that mean that we can offer that rapid access and treatment.
Thank you. Jemima.
Thank you, Chair. This may not be for you to answer, but how does the 111 service fit into this winter preparedness plan? Because there's no mention of it in there at all. And I just wondered how they dovetail into what you're planning. And in fact, then maybe before the scenario that Mary raised, actually when somebody maybe might start that process with a 111, just how they are kind of readied to implement this plan and the part that they play.
Peter, thank you.
Thanks, Councillor. And so part of the improvement programmes that we have driven this year to attempt to bolster and overlay the work of previous years is particularly to focus on 111 triage and to improve the clinical assistance to our 111 teams so that there is a more nuanced ability to provide signposting to patients through 111 service to alternatives to the ED admission. So 111 and our ambulance colleagues remain integral to our ED demand management meeting that we have fortnightly and contribute to that collaborative work. So it is a focus for us this year.
You happy?
Yeah, I would just like to see and maybe you'd say it's not the right place for it, but I would like to have seen at least a sentence or a mention of it in this, because if we're taking a holistic approach to getting this right, I would have thought 111 was really key.
Quite agree. Steve, you want to come in?
Thank you, Chair. This is it's a really good report, well received, thank you. It's really great to see vaccination wove through the entire thing. We know that vaccination rates nationally are going down, and it's a challenge for us in Plymouth as well. It's probably just an opportunity to make board members aware that as of yesterday we launched the Plymouth Protects campaign, which will dovetail with everything you're trying to do, which will be a range of hard copy and digital assets in trying to promote and encourage vaccination this winter. Very mindful of what happened to you in January, and knowing that you had 150 people in your hospital that probably didn't need to be there because they had vaccine preventable diseases. So just again for board, last year flu vaccine uptake in the over 65s was 77% and COVID in the over 75s was 71%. So it's not a bad uptake, but it's those vulnerable 30% that aren't having it are the ones that are probably going through your doors in some shape or form. So it's really just an additional thing that we can do to try and promote that into the community space. And then my question is, when you, in your report where you talk about your vaccine program focusing on those areas that are harder to reach, can you just unpick that a little bit for me as into what are those hard to reach areas and how can me and my team help you in that space? And counsellors.
Absolutely, so our Live Well colleagues are going to be the forefront of it, and certainly Ian's team with Lou Higgins is coming up with plans with our community partners and how we're rolling that out. So that I don't have the answer to the question for you on her behalf, but I know that she is trying to work with the community teams.
So is this about hard to reach residents, in which case I feel like I understand that. Yes. The way it was worded made it sound like this was staff focused, and I'm just interested in if there were particular residents. Staff. Okay, that's fine.
Sorry, apologies.
But I would say, Stephen, I think responsibility that we have of all board members is, and saw LinkedIn yesterday, and we'll come out with the vaccination programme next week. It's really important that we promote as role models to our organisation, our public, the importance of vaccination. It is absolutely the most important thing we can do to protect ourselves and our loved one, and the winter capacity across all of our services. over the course of the winter. Our staff vaccination levels are lower than the national average, so we've already started our campaign. We have a huge amount of work happening. We've made improvements this year. One of the challenges last year was we didn't have a dedicated space. We wanted to make it very dignified and very welcome for people. We've reformatted our wellbeing spaces within the hospital just temporarily to make that a scenario where people can easily access that. But I would really ask the help of all members. We are both represented in our own world, but the organisations, it is really, really important we encourage our staff, because of the way that they move around, to be vaccinated, to protect themselves. They can come to work and we have a workforce, but also to carry on and provide the care that we need for our patients and our loved ones.
Can I just ask, how are we managing our PCC staff's vaccination system? Have we got anything pulled together yet, Gary?
So we haven't got an overall workforce vaccine programme in place this year. Our focus was very much outward focused into our residents, but next year we hope to have one in place. That being said, those that are within those vulnerable groups, so health and social care workers, which would include social care, would be eligible as part of the NHS programme.
Great stuff. Peter, you still got your hand up there, right?
Yes, two just brief points, Chair, if I may. One is to echo what colleagues have already said around vaccination. When we look across the system at the influences of winter pressure, nearly all of those influences in one shape or form are through respiratory illness. So either staff members being absent, which adds pressure to the system across all of our organisations, at the same time as people being ill, and the knock-on effects of respiratory illness to other long-term conditions. So the earlier we can get vulnerable groups vaccinated, the more protection we will have, the more buffer we'll have going into those pinch points we know inevitably will come. The second point, Chair, was just to the previous point about 111. And just to recognise that the winter plan you have before you today is the locality and provider winter plan. It's nested within our system winter plan, which has more detail about those schemes that we are offering across Devon as a county. We would be happy to share that with the committee for further scrutiny if that's helpful. And I think that would be where you would see some of that extra information.
Thank you. Yes, please, Peter. That would be really useful. And also, we need to think about how, as a council, we have something on our websites, etc., for staff members, don't we? I think that needs to be sorted. Patrick.
Thank you, Chair. Certainly, the vaccination programme, I think, is extremely important, and the overarching presentation is very, very much welcome. I wanted to drill down a bit more in terms of, and really bring probably Louise in relation to adult social care and those providers that provide assistance in the community. So what are we doing as a local authority to not only those that we contract, but those who provide services in the community for adult social care in ensuring their staff are vaccinated? What was the percentage last year that were vaccinated who were employees in that sector? So at this point, I would exclude the hospital sector. These are people that are being cared for in their own homes. So what was the take-up rate, and what's our target, and what are we doing to communicate with those organisations to ensure that where it's led by the employer rather than the employee, that employees that generally want to have a vaccination but the employer is not on side, what are we doing, please?
I'll go to Gary for that.
Thanks, Councillor Nicholson. I think it's fairer for me to try and answer that question today. What I would say is from last year and our learning, which is why it's so great to see the focus on vaccinations this year, because I think what we noticed last year generally was a bit more kind of weariness around vaccination. And that would be the same experience through our care markets where we actually saw lower numbers. We can get the numbers, I don't have them in my mind, but that's why I know we started quite early in the year, the whole conversation around how we improve vaccinations. From our perspective, they're a really core part of the vaccination programme, and we want to push as hard as our friends in Livewell and UHP around their staff, around making sure all staff providing care are given that opportunity and hopefully accept that that challenge of having that, because we know the effect it has on our workforce, which doubles the effect of having more people to care for, and it just increases the challenge, which is why I'm so pleased to see it in the programme. We already have a range of provider engagement sessions that go on, and to build into, just to lead that into my point, it would be really helpful to get assurance around the monitoring, and then us being able to wrap tactically around those areas where we see there are groups perhaps not at the uptake levels that we need, and it's a point I was going to raise. So we've got the systems there. That's why the planning started so early. I think what I would really like to see is the monitoring of how we can try to understand success, and then wrap that around tactically. So I think, Patrick, is as critical in our care markets as it is for our hospital colleague staff, and to make sure anyone who is vulnerable goes and gets that vaccination. So hopefully that's helpful.
So Chair, can I just come back on that, please? So thank you, Gary, for that. It would be useful to have some statistics. Can you give an assurance, though, that employers are on side where they're providing healthcare, and that therefore, if staff generally want to participate and have vaccination, they would have the ability to do so? I think we need to, obviously, we're all aware, but restate the fact that many of the providing care in the local community are generally younger population who have children. Children spread an awful lot of these issues around, and clearly a number of them are in the category of being vaccinated. But it is important that we highlight, and I know that we had issues with COVID vaccination where there was generally resistance. I'm not sure if I don't know if you can confirm, Gary, or anybody in the room, whether there's resistance against flu vaccination as there was against COVID vaccination. The myth around COVID vaccination, which obviously many of us didn't support, but it's just important that we not only safeguard the hospital, but safeguard those that will want to remain in their own homes, that there's the opportunity of staff to be vaccinated as soon as possible within the timetable. Thank you.
Steve, do you want to come in?
So I think I can pick up on some of those points, Councillor. There's definitely a piece of work Public Health can do to look into that, because I'm pretty confident the broader health and social care workforce is recorded in regard to that. I can't apply this to Plymouth, but my experience elsewhere is when we saw the COVID vaccination introduced, we saw quite disappointingly low uptake through health and social care staff. And then although we saw slightly higher uptake, we then thought that flu would follow that, and actually people then chose not to have flu. So it is a real challenge in that space. You're right. I don't think I've ever encountered a health and social care provider that has been anti-vaccination. The challenge really is in trying to dispel the myths in staff, and I think the point you made is really relevant, which is younger workforce that don't necessarily see themselves as vulnerable, but don't understand the impact of being vaccinated positively on protecting those that they're engaging with. So I can take that as an action and bring something back. Thank you.
Thank you. I've got Ian and then Chris, but I just want to say something to David. Presumably we keep an eye on what's happening with our looked after children, etc., through a process of checking that they've had the vaccines that they're eligible for.
Yes, Councillor Aspinall, I confirm that we do, and that does get reported through to the Corporate Parenting Board. And given the conversation today and the fact that that's been raised, I will just ensure that there is a focus in the health report to the next Corporate Parenting Board on that, both in terms of what we've achieved so far and the plans for achieving that with as many of our children looked after as possible in this season.
Thank you very much.
Thank you.
Ian.
Yeah, thank you, Chair. I felt I should respond to Councillor Nicholson's question. I know it was directed at social care, but it's the same principle for Live Well teams, who are ostensibly going in and out of people's homes on a regular basis, seeing thousands of people. So I can give you some data. Our uptake last year was around 40%, which is nowhere near where we want it to be. So this year we set a stretch target of 60%, recognising that's still not where we want to be, but given we've got a 40% from last year, we're aiming for that. And we've taken a number of additional steps this year, including surveying every patient-facing role to understand if they are intending to have the vaccine, and if they're not, whether they're prepared to share their reasons why, and a whole load of other campaigns as well. The only other thing to add for us, there's sometimes an issue in capturing all the people that have had it, because if they have it through their GP, they need to tell us they've had it. And again, we're making sure we're doubling down on that as well. So not enough from last year, very similar to the comment Steve made around trying to support people to buy into it, and explaining all the reasons why it's essential from our point of view. So thank you.
Chris?
Thank you, Chair. So just to add a little further assurance on the back of Gary's response to Councillor Nicholson's question, absolutely essential in terms of making sure that we're supporting our domiciliary care providers and those in the community. And we had mentioned our forum, Dom Care Forum, earlier this week, so on Wednesday, where we had a specific focus session on winter planning, and vaccinations was a key component within that. And it really did feel positive in terms of actually those providers working together to find solutions to maximise the reach out to their staff, and offering drop-in sessions as a mobile unit that's been likened to a ice cream van, that we're making sure is supported to find those opportunities that those workers who are out delivering an important role out in the community can drop into other places that aren't just necessarily their employer, and really working together to make sure that we're promoting and making those opportunities available. As Gary said, it's really key that we monitor and triangulate that back as the winter goes on, so that actually if we find that there are other areas and other things that we need to be doing to support alongside those employers, that we do so. And that isn't just about health and social care funded packages of care, it's about our whole market, so that we've got that full breadth.
Thank you very much indeed. Right, Rob.
Thanks, Mary. This is a very parochial question about voluntary sector workers who aren't providing direct care, but are dealing with a massive throughput in terms of older people. I'm just thinking about the Ageing Well event yesterday, when we're bringing lots of older, frail people together in community spaces. So in the past, we have been eligible frontline staff in the Wellbeing hubs, for example. So would that still be available, or is the onus back on the employer to arrange vaccinations?
We can't, there's nobody putting their hands up quick, so what we'll just take it away and come back to you, Rob. But there are categories, aren't there? And they are in fact written in here as to if we will, but we'll see, we'll certainly see. And
happy to take that action to clarify that point, Chair,
thanks,
and come
Chris,
back to Rob to
that's
confirm.
great. Oh, Rachel?
I was just going to say, I think it's all in a collective effort. If we can find a way to do that, I'm sure UHP would be happy to help. I think it's a really important, same with Ali, one of the colleagues, I think, let's find a way to support that. I think it seems really important.
We will get back to you, Rob. All right. Patrick.
Thank you, Chair. It's really just obviously trying to bring this to a conclusion. I think it's essential in this winter pressure season that we capture data. And I think probably, Steve, you're the best person to coordinate the collection of data across the piece in relation to vaccination of staff, particularly, so that we can, as LiveWell have got a target, we know what the data is, we know what the target is, the aspiration is. At the moment, we recognise an issue, but I'm not sure outside the acute hospital and LiveWell that there is much of a target. There's an acknowledgement there's an issue. So I would impress upon our side of the house in many ways that we actually know what the problem is and know what we're trying to achieve in the future. So if that could possibly be recorded in the actions for the meeting, that'd be really great. Thank you.
Thank you very much. I'm happy to take that as something that we will look into and see if we can get facts and figures for that, not a problem. So the recommendation is that the Health and Wellbeing Board review, comment and endorse the plans set out within the report. But what I'd like to also add is, and that we will have feedback on this at a subsequent Health and Wellbeing Board meeting. Are you all happy with that? Okay. Thank you very much. Right, so Chris, it's now for you, isn't it? The NHS 10-year plan and the integrated neighbourhood teams. The floor is yours.
Thank you, Chair. So a few slides to share. There was a fuller feedback in terms of the 10-year plan engagement findings that's been provided as part of the pack, but I'll just take you through a few quick summary slides. So as members will recall we presented previously as we launched the engagement process around the NHS 10-year plan, and I've also spoke previously around the emerging work and guidance that's been shared around integrated neighbourhood teams. The NHS 10-year plan itself has now been published, and that's given us some further guidance that I'll take you through. But in terms of the engagement work itself, so that was launched nationally in order to inform the development of the 10-year plan. The 10-year plan was published on the 3rd of July. It centres on what the government's 3 key shifts, so a greater focus on how we move from acute to community care, greater role from analog to digital, so maximise the opportunities around digital, and absolutely essential that we have that focus from shifting away from treatment to prevention. Lots of focus around how we reduce waiting lists, make sure that we've got care offers that are convenient for individuals, but also tackling some of those inequalities and moving forwards with that prevention work. What that's then also worked alongside is the new operating model, including from an ICB perspective, shifting our focus to be strategic commissioners and delivering what are essential running cost reductions within our own resource in order to free up resource that can be focused absolutely on frontline and support. And workforce is absolutely central within the 10-year plan, recognising that we need to make sure that we've got a staff workforce that's better treated, more motivated, and have training and scope to develop their careers. So locally within Devon, our engagement plan that we launched was hugely successful in terms of across the whole patch, having a range of different opportunities for people to feed in their views and feedback around the NHS in order to inform the development of the plan. And indeed, the Devon approach was one that was considered a leading example by regional colleagues. It had a huge amount of response, lots of engagement. Within Plymouth, we held 2 workshops that were really well attended, and I know was supported by some of the members on the Health and Wellbeing Board. We had drop-in sessions at the library in town and other opportunities that people could feedback directly. And you can see some of the stats there in terms of the amount of Devon feedback that came through and actually represented quite a significant proportion of the feedback that was received nationally came from the Devon system. So absolutely the Plymouth voice and Devon voice was heard by the national team in the development of the plan. Locally, in terms of the overarching feedback themes that we found, so people really value NHS being free at the point of access. That essential component in terms of the workforce are the most not only the most valuable, but also our most vulnerable asset. Making sure that people have a range of access to services that are available to them and that we've got that personalised approach so that it's available to them in the way that makes sense to most of them. Primary care and mental health, waiting times, making sure that we've got access. A recognition that actually satisfaction levels of how the NHS is run is low at the moment, but that's similar across the national picture. And there was also a clear message that funding the NHS sufficiently should be a priority. So how that then maps into the 3 key shifts that are outlined within the 10-year plan. So moving from hospital to community, absolutely a need to and a reflection and recognition of more investment in frontline services and reduction in management costs, making sure that when people access service, they have a positive experience. In terms of the shifts of sickness to prevention, making sure that we've got better access to diagnostic and preventative services and more education strategies to help people build confidence in taking ownership for their own health and wellbeing. In terms of the shift from analog to digital, so making the most of the opportunities in terms of advances in technology, concerns around mistrust of AI and a need for us to make sure that we can allay people's concerns about reliability, data safety, and the opportunities that can help in terms of it addressing, but also making sure that we don't exclude inadvertently groups by having digital offers for those that might be digitally excluded, and also a more joined up approach across health and care. So alongside the publication, as I mentioned, around the 10-year plan itself was the publication of integrated neighbourhood teams, and I've spoken at a previous health and wellbeing board around what this means for us, what it means in Plymouth and the opportunity that presents. Subsequent to that, with the publication of the NHS 10-year plan, there's a really, really clear message. It's the golden thread that runs through many components of the 10-year plan as an operating model, shifting to a greater neighbourhood focus, and how we shape our offer to develop that. The work that we've been undertaking in Devon, so we recognise we're on a development journey. There are already a huge number of really positive assets and example of integrated teams working at a local level. But what we need to do is make sure that we're taking the best of that, developing that alongside the national guidance that's come out, the 10-year plan, and also from a Devon health system, our emerging health and care strategy that's due to be signed off by our board later this month, and will then be shared with partners. We recognise, as I say, those assets that we've already got at a community model, and that actually that can act as a grounding as we take forward that work. We've got a Devon-wide steering group that's coordinating that across Devon, but actually the local development of what our neighbourhood teams look like and how we bring together partners in order to deliver and embed that is being driven through our local care partnerships, and our Plymouth LCP is absolutely central within that. Also during the summer, there was a national neighbourhood health implementation programme that was launched nationally, and that invited 42 places to join a national development programme in order to access some additional coaching and support, in order to drive forwards the implementation of neighbourhood delivery. You can see a summary there in terms of the application that was pulled together on behalf of the Plymouth system. That was a very, very short window that we had, 3 weeks during the peak summer period, in which to pull that together. But there was a phenomenal effort from all partners in order to support the development of that, bring together some of the strengths and assets that we've already got, give some consideration to some of the specific challenges that we face in Plymouth, some of the deprivation challenges that we've got, some of the examples of inequalities that we know that we have, and think about how we could take forward a programme of activity in developing our neighbourhood that responds to those pressures that we have. There was a sign-up of 25 partners in the end, who committed to the application that went in, and actually that was the highest number across the whole of Devon, so that reflects the strength of commitment that there was within the Plymouth system. Unfortunately, we weren't successful in that first wave programme in terms of the application that went in. However, we've had a number of conversations with NHS England and the national team since then about how they can support us in not only driving forward the programme in the meantime, but also how we position ourselves to be at the forefront of an application for Wave 2, which we're expecting to be around March time next year. We've had conversations with all partners who are part of the application that went in as well, and there is a absolute commitment from all partners to move forwards with the work anyway, use the work that we've done as a grounding. But actually what we've also recognised is if we've got a little bit more time, what we need to really do is go back to revisit some of those foundations. So make sure that we've got that really clear understanding of that focus, our vision for what we want our neighbourhoods to deliver within Plymouth, that absolutely responds to local communities, how we build on the strength that we have in terms of our really important voluntary and community sector partners who hear that voice of the Plymouth population, that we're collaborating and co-producing our offer alongside primary care, and the acute and community services and the local authority. So we'll be moving that forwards in the coming months. We can provide further updates in future sessions. Also looking at actually if there are some areas that we can pilot some initiatives that we move forwards with those now in order that we can take things forward, learn quickly, and identify opportunities that we can spread. Mentioned briefly earlier the Devon Health and Care strategy that's imminently being published. So this is draft at the moment, but just to give a little bit of insight in terms of the emerging operating model that's articulated within that. And as you can see, what we're reflecting is a neighbourhood delivery model that's built around community services for populations between 30 to 50,000 people, that we look at how we bring services across health and social care and the voluntary community services in order to deliver as many services as we can through that. but also then a place model as well. So where it makes sense to join some of those services offers because of scale or specialism, that we have a offer that is at a place level in order to do that, but still reflecting that neighbourhood model, pulling forward what's important from a community and service user perspective, in order to join up alongside partners. And then equally recognising there will be some really specialist services that need to be done at a higher level, perhaps even across Devon, where that makes sense. That's the most efficient way to deliver it. But absolutely structuring our operating model as we move forwards and deliver against and embed the principles that are set out within the strategy as part of that. In terms of the neighbourhood activity that sits alongside that, so recognising, as I've said, that commitment that we've got across Devon really to drive forwards our development, but very much thinking about, as that strategy is published and as we need to move forwards with our neighbourhood delivery model, there are some core things that need to take place, and this kind of starts to map some of that. There's more work that needs to go into this as we pull together the other service components that we will map into and dock into our neighbourhood model, but this kind of starts to outline some of our ambitions and requirements in terms of developing our neighbourhood specifications, so what we want our core offer to look like, going through the procurement processes that we'll need to, and having a model that enables us to deliver. And as we move forwards in line with the NHS 10-year plan, shifting more services into that community place as a delivery space, recognising there's a lot of ambition in terms of our ability and need to move this forwards at pace. What we're really focused on in the current year is how we undertake the steps that we need to around that formation of our neighbourhoods. So working to build on the conversations that are already taking place to develop that neighbourhood working, defining our neighbourhood footprints, some of the other tools that I've spoken about in previous sessions that are core components of a neighbourhood delivery model in line with national guidance, that we've got those in place, things like having a clear risk stratification tool so that we can understand and identify population need and drivers in a local area, and reflect our development in line with that. And also looking at our local care partnerships, so really real strength in Plymouth in terms of our LCP, with real commitment from partners, but just making sure that we've got that grounded within a neighbourhood delivery model, and reconnecting to make sure that aligns both of the priorities within this, but also the other programmes and activity that are taking place across other partners too as part of that work. Recognising that, as I say, in terms of our focus at the minute on that formation of our neighbourhood stage, as I've described there's a number of key components that we're taking forwards in this year, but also giving that freedom around actually connecting that back through our LCP to identify where there are pilot areas that we could test some things that fit alongside the guidance that's been published, that we do that at pace in order to make sure that we're improving outcomes for individuals through that delivery model, but also getting the learning in so that as we develop that, we can take the best from that and ensure that we share that. But that in is, as I say, quite a quick summary of a more detailed report in terms of the 10-year plan, and also just a bit of an update in terms of where we are around our neighbourhood development within Devon and Plymouth specifically, but really happy to take any questions that members have got.
Thank you, Chris. I'm going to start the questioning by, it's talking about neighbourhoods, and that is one of those things that is all the way through the 10-year plan, etc. How much input is the council going to have within these neighbourhood footprints? Because obviously Live Well will be needing to know that, we'll be needing to know that. So I think, how are we going to get those neighbourhoods agreed?
So it's really important that our neighbourhoods are developed that are co-designed in terms of the footprint alongside all partners, and that's the strength and benefit of bringing this in through our local care partnership. So Gary and Steve and David all sit on the LCP executive that's chaired by Tracy. So we've got a real strength in there in terms of the local authority, but also ensuring that in developing our neighbourhood model, there's a real opportunity to, in terms of the Test and Grow programme and the work that the council are leading and developing, that this all comes together really neatly. So we absolutely, and so it's really important from a local authority perspective, but Live Well are in that space, as are UHP, as are representatives of the voluntary and community sector as well, along with primary care. So it's quite a complex process in terms of mapping neighbourhoods that respond to all those services, and how we bring together partners across what we've got at the moment, very different footprints in terms of that service provision. But I suppose central to all of this, though, and it's really clear in the guidance and our approach, is it needs to respond to what most makes sense to the population and the people who receive services. So working together to understand the insights that we've already got around what most makes sense, what the natural communities within Plymouth, and then working with our partners to agree what the footprints look like around that. So it's quite a complex process to bring all those pieces together, but that's something that we're taking forward at pace through our LCP now.
Thank you. And of course, LGR throws another spoke in the wheel, doesn't it, really? So, yes, watch this space. Peter, you wanted to come in?
Yes, yeah, thank you. And inevitably, we've heard a really positive and quite rightly optimistic view of the world, and there is always an importance of tempering that with reality. And I think what we've heard is the insights of our population and them aligning with the government's aspiration to change healthcare delivery to a much more localised model, something that we have been working on for many years. We know that reducing duplication and handoff will help increase efficiency and make the experience better for our population. But that does mean that healthcare will change considerably. And I guess there's an ask from me of a recognition that this is not as well as all of the services we currently provide, but we'll be offering an alternative. And we all need to stand together, I think, both as public servants and elected members, at really being able to describe that this is a better model of provision, but it does require some change. And that change we need to describe to our population in a palatable way. Otherwise, a lot of these aspirations will get stuck in the implementation phase.
Thank you, Peter. Andy?
Thank you, Chair. I'm really interested reading the statistics of this report. I mean, starting off with a sort of light-hearted note, one of the respondents on his ethnicity background says he's a Devonian, and that wasn't me, members. I didn't put that in the survey. What is alarming, of course, is the level of customer dissatisfaction in the public surveys. I mean, it accounts for the vast majority are either dissatisfied or very dissatisfied, which is very worrying. Looking at the staff statistics on the reports on page 52, I mean, one thing I can understand as an organisation, there's going to be a resource issue in as much as medical staff come at a premium, there's always going to be a high level of demand which outstrips that. But one thing I don't find acceptable is the lack of joined up IT. Now that is something which is a technical issue, which in the modern day with AI and everything else that we have, there should not be a disjointed IT system. That should be the least of frontline workers' problems. What work is being done to address that, please?
Councillor, Peter, I don't know if you're best placed to respond to that. Do you mind picking?
Yeah, so I'm happy to respond, Chris, unless you feel that you want to. So, Councillor, I think you're absolutely right. We have a number of different systems that meet the needs of different parts of our healthcare provision and indeed the wider social care provision that traditionally have not joined up well. There's a whole architecture digitally in the background that allows us to extract and exchange information now, and continuing to align systems that we're implementing that front-facing look different, but behind the scenes can share data in a much more joined up way is a real focus of both the regional and our system digital progress for the next few years. So for me, it is about, as a user, both as a citizen and as a member of the workforce, we may need to see different bits of information in different ways, but those bits of information behind the scenes should be interchangeable for us to analyse and join up. And that's the programmes of work that are in place.
Thank you for that. I've got Steve, then Jemima, then David.
Thank you, Chair. Chris, can you just offer some clarity on the role of the Health and Wellbeing Board in the integrated space? Because I think my very naive understanding is that Health and Wellbeing Boards will have oversight of the neighbourhood plans. But I think there was also something associated with a really tight timescale, which absolutely doesn't align with the Plymouth battle rhythm for Health and Wellbeing Boards. Could you just offer some clarity that you may have at this time? Because I think it's important for members to be aware. Thank you.
Yeah, thanks, Steve. A really good point, actually. You're absolutely right. So whilst we're using our local care partnership as the engine to take forwards locally, the Health and Wellbeing Board has a really, really important role in terms of overseeing that work, and the guidance, all the guidance is really clear in terms of that responsibility. As part of our annual operating plan process that we go through, the guidance has been published nationally, talks about a neighbourhood health plan that needs to be developed and signed off by the Health and Wellbeing Board. So there'll be that process that we need to go through in terms of developing that and getting that sign off through this board as part of that annual process. Unfortunate, so the timelines that are quite tight, and unfortunately we're still waiting the publication of exactly what needs to go into that plan, but we are anticipating that soon, and we'll obviously need to, once we've got that, map that back against the timelines and this board to make sure that comes through. But even running alongside that then into the future will be how this board has a responsibility in terms of monitoring against the delivery of that plan that's developed, and absolutely the development of the neighbourhoods will be a key enabler of that.
Thank you. Yes, that's a really important point. I think what we will need to do is to see whether we need to put any additional Health and Wellbeing Board meeting in to make sure that we're within that cycle time. So I think that's one thing we need to know, Elliot. Okay. Right, I have Jemima.
Thank you. Mine was a question around young people's input into the consultation and the engagement process, just how that was facilitated for young people in Plymouth and what kind of input they had.
So I would need to go away and double check on that one. Unless Peter, you're familiar with no. So I know certainly in terms of some of the themes and the voice that was absolutely captured. The process that they went through and the components of that, I can go away and feedback.
Thank you very much, David.
I just wanted to raise another government agenda, which for children's is the delivery of the Families First programme. So national expectations, biggest changes for children's social care within the last 40 or 50 years, and that includes a locality-based delivery model expectation. So I just wanted really to assure the board that whilst there is no presentation of alignment at this at national level, and it does appear that two departments have done two very separate things in terms of going out separately and setting separate expectations, but the core of what they want to achieve is the same. So we will make as much sense of both of those locally as we can as we develop up the locality multidisciplinary working model for children and young people, and we will have those discussions, continue those discussions that we've started through the LCP on that, and ensure that for our population and our communities and residents there is as much alignment and join up of those two elements of work as possible, so that we have a responsibility, don't we, to make it make sense for people on the ground in Plymouth, and we will do that. And Ian is very helpful in his leadership of that with us. So I just wanted to raise that in relation to that Families First programme, and B, just to provide the assurance that we will work collaboratively and collectively on that, and make as much efficiencies and as much alignment as ever possible. Thanks.
Thank you for that input. Patrick.
Thank you, Chair. You touched on just in passing about local government reorganisation. It's probably quite important that we actually hear as politicians perhaps advice from our professional health partners in relation to the best boundaries for delivering healthcare in Devon. Now, I don't want to put any of them on the spot, but it would be very useful to have some feedback from health partners as to when we come to deliberate and come to decisions at the end of November on the best pattern of local government for Devon, the whole of Devon, including Plymouth, that we actually have some input from health partners, because you know on the ground how you deliver healthcare in the county of Devon, and you know probably the best communities and the best fit for that healthcare provision. So it'd be very useful through you, Chair, to seek views in the coming weeks from health partners on what your view is on local government reorganisation and the impact that will have on our partnership between local government and health provision for our local population. Thank you.
Chris, is that something that you've been looking into with your magic wand to see what might come out of it?
We've certainly been briefing through our local care partnerships as well across all partners, and the health representatives that are there in terms of the process and that awareness. I think absolutely in terms of some of the learning that we've got. So at the moment, none of our services actually neatly aligned to local government boundaries. So I think there's some learning that we can take and share in terms of how that's worked in practice and some of the benefits and challenges associated with that. So I think certainly that's something that we could think about how we best support sharing some of that, connecting that as an ICB on behalf of the health system to bring that back through. I don't, Peter, if you wanted to add anything in that.
Just very briefly, you probably covered it off, Chris, that at a strategic level, as we continue to explore how the cluster across the peninsular population will operate, we recognise that there will be some greyness, particularly in that how one might align neighbourhoods together, which will be very much obviously around local government footprints, because that's what local government is all about, isn't it? About communities and neighbourhoods. When it comes to place and that sort of second order and services that need to be shared across, we recognise that probably there is a different conversation to be had around patient flows and how best to serve the population in terms of healthcare provision. And we don't need to necessarily have a one-size-fits-all. There may be some greyness and flexibility which we all need to operate in. Happy to bring that back. And I'm sure as we continue to refine our thought processes strategically as a cluster, we would want to very much involve local government partners.
Thank you. And I mean, I know Donna, the chief exec from Exeter, is on the board as well. So and we all know that she is vocal and is well engaged with the process. So that's good. So I've got David on there. Patrick, do you want to come back though first?
Back if I may, before David comes in. So that's very helpful. Thank you very much indeed, Chris and Peter, for that. Could I just ask you to actually share, the system and the health community's view with all councillors and not rely on it being funneled through sort of representatives on panels, because all members of the local authorities will be asked at full council to give a view on local government reorganisation. Communications aren't always that great, so actually direct communication from the health partners with all local councillors would be really useful. Thank you very much indeed.
I'll take that on board as well and make sure we get something. Right, now so I've got Rachel.
Thank you, Chair. So just to feedback on behalf of UHP, the focus on integrated neighbourhood teams is really welcomed. I think it's absolutely epicentre of attempts we've had over, certainly my career, 10, 20 years to try and put connected care, whether that be health or voluntary sector, primary care or social care, at the heart of communities and where they live. And we know that will mean we and others will need to change. And I hope we've made some inroads in that with some of the work we've been doing around acute investment. Some 6-7 million has been invested into community care over the last year, and having some really good conversations with primary care too around funding flows that may move to provide care closer to home, or indeed some of our resources out. So I just wanted to put that on record that we are supportive of this approach. It does mean that will change some of the shape and size, but committed to do that in a kind of co-design with our partners. I think what's going to be critical, so I'm always a bit like this on the boldness, but there's a kind of 4-year timeline for some of that. I'd hold ourselves to say given the increases we've got, particularly in this locality in the next 5 years, another 10% in our frailty population in particular, whether a 4-year timeline is right, and whether we should be a bit bolder around that. And secondly, and it's the dull bit, and people who've heard me speak know it's a bit of a thin one, but the governance around this and getting this right, because we are going to have to be more than a partnership, I think, in coming together. We are going to have to think about how we share risk and gain, how we have connected, whether that's IT, whether that's how we train, whether it's how we have clinical governance systems. So we are going to need that bit alongside, but I think we're in a really good space as a partnership to do that. And then one small thing on the plan, we don't mention at all tertiary. I know there's the word specialist, but I'm really proud that we have in this patch our tertiary and special, which is more than specialist care. And I think it would be really great if we could just add that back in the document, the fact that we can do transplants, major trauma care, and that's available to Devon and Cornwall. I feel it's a real shame that's been lost in the document so far. Thank you, Chair.
Thank you. That's a good thing. We need to see if we can get that into the document. As you say, it's essential. David, you had your hand up?
No, I hadn't put my hand down, so apologies.
A legacy one, that's fine.
Legacy hand, yeah.
Right. Okay, I'm conscious that we're a little bit behind the timetable. If you two, because I'm really interested, Rob, in what you're thinking about the community aspects from that. So Gary first, and then Rob.
Thanks. Sorry, I guess firstly just wanted to emphasise and reiterate the point Rachel's made around the governance of how we do this. This is a really huge opportunity for our systems. And even if you think about our agenda item previously around winter planning, one of the key focuses there is around how you keep people at home, how you keep them looked after well at home. Well, that's the whole neighbourhood agenda. That's the prevention agenda, which is so important for all demand-led services. So the opportunity inside of this is huge, which makes the governance really important, because we are starting to knit together at place lots of different things that are going to play into those spaces. So I just wanted to, and I think that also talks to David's point around the Families First agenda, where we have got that opportunity to knit together at place lots of things that are going to really matter to people, but to families and units of others. So I think it's just a huge opportunity for us. And I would like to see that kind of governance described really well and thoroughly, so that we've got all of that in place. That's really going to help us maximise the benefits of it. So I just wanted to make that point.
Thank you very much. Rob?
I think there's an inherent problem with the programme name when we start talking to local communities. Neighbourhoods can make sense in terms of a system perspective. When we talk to local communities, wellbeing hubs, when POP have been holding their conversations around this, the immediate pushback around a neighbourhood being 30 to 50,000 people just alienates people immediately. And we do know that within a neighbourhood of that size, we're going to have the flexibility of co-working and integrating services at for certain groups and for certain conditions, to work at a hyper-local level. But when we just start using the terminology integrated neighbourhood teams with the wider community, it doesn't resonate, it'll alienate people. So it's fine to be used in these circles, but I think we need to think about public messaging about this whole approach. Otherwise we'll just turn people off in terms of their engagement right from the beginning.
I quite agree with that. Ian?
Yeah, thanks, Chair. I, with my Michelle hat on, I think she'd be rather unforgiving of me if I didn't also stress Liftwell's support for the neighbourhood model. Obviously, as a community provider, this is what we consider to be our bread and butter, and so we really welcome it. Just one other observation, fully support what Rob's just said as well in terms of how we communicate and engage and the language that we're using. It's not a good fit for our communities, and we're going to have to do some work to help translate what neighbourhood means. And maybe consider how we do that when we're having our conversations with our citizens. I just wanted to observe the significant energy that was created through going for that bid. Just an observation in that 2-week period, and how it brought everybody to the table. And we surfaced a number of really important areas where we aligned, and some other areas where we might need to do some further work. And completely support the fact that we've got this period of 6 months to perhaps go for a wave 2, but also in line with what Gary and Rachel have said, really keen to see the governance accelerated so we don't lose the energy that we built up during that period in the summer, which was really positive. And I think we're sort of just a slight risk now of that going cool. So the sooner we can kind of progress with that, whilst recognising it's complex and we don't want to charge at it, the better. Thank you.
Thank you. Yes, I can see the logic in that. I mean, one of the problems is that, of course, not all GPs have a very neat area that they work with. You can have a GP down in Devonport that's got people coming in from Plimpton and things like that. So I think it all adds to the mysteries of life, doesn't it, really? Okay, folks, the recommendation is that the Health and Wellbeing Board review, comment and debate the content of the report, which we've done, its implication and next steps for board partners. And I think we need to add into there that we need to be kept informed, and if there is an additional meetings needed, we are agreed that that will happen. Are you all happy with that, folks? I'm sure Elliot will phrase that better than I've done there. Okay, can I have a vote on that, please, folks? Great stuff. Thank you. Right. Thank you, Chris, for that. Much appreciated. And keep in touch, as they say. Thank you very much. Right. Now, let's move on to NHS Devon ICB's dental service update. Peter, are you going to start?
So I'm going to introduce this, if I may, Chair. So I am joined by greater subject matter experts than myself. I think we are today giving the board an update on both the national position and our local response to that. I think all of us in the room would recognise that both primary and secondary dental services are not at the place that they need to be to serve our population, and we recognise that that's a national issue and not just a local one. But it is really important that we are able to demonstrate to yourselves and the public that we are doing everything that we can to explore and continue to explore new and novel ways to provide the care that our population needs. But I will hand over to Melissa and Matt to give more detail.
Thank you.
Thanks,
Melissa?
Peter.
Yeah.
Thanks, Chair. So I'm just trying to share the slides. A second. Oh, there we go. Okay. Can everybody see that okay?
Yes, we can. Thank you.
Perfect. So thank you for inviting us to come and talk to you today around dental services. So unfortunately, our clinical dental lead for Devon was unable to attend today because of annual leave, but pleased to say, as Peter did, that we've got Matt Drury, our Regional Chief Dental Officer, here today. So I'm just going to start off with a bit of a national update. The dental contract is a national contract, and I think it's fair to say that nationally it is recognised that this contract is not fit for purpose. So the government has reiterated in its latest contract, in its latest consultation, that it's fully committed to fundamentally reforming the dental contract. However, the latest consultation includes interim measures aimed at addressing those most pressing issues rather than the full dental contract reform. So that consultation closed in August, and it's anticipated that any changes will be introduced in April 26. So we're not expecting that there's going to be considerable change to the dental contract at this stage. So it's not moving away from the units of dental activity model, but some changes made to improve the attractiveness of that contract. Okay, so I'll take these slides as read and I won't go through them in detail, but I think the key takeaways are that the changes are focusing on those with urgent needs, significant dental issues and children, and allowing for better use of skill mix and including prevention. So I think in summary, the expectation is that overall these changes will hope to improve the delivery of the contract and job satisfaction for the patients, profession. So since writing these slides, the national team have announced a national urgent dental care incentive scheme to be offered to practices. However, we have already offered a local scheme, which we believe to be more attractive in terms of finance and supporting providers in terms of operational delivery and cash flow. So we are not expecting to see much impact from this, but it will be offered to all eligible practices anyway. So we're just waiting to hear the outcome of the wider consultation, and then the next steps for us will be moving into the implementation phase and including those changes within any contracts. Okay, so this slide provides an overview of our local dental recovery plan. So there's a few points that I just wanted to draw out. So urgent dental care remains the team's top priority for commissioning, as mandated by the government, to provide our share of the 700,000 additional urgent dental care appointments. However, we do also recognise that the importance of a seamless service for patients. Therefore, we have also commissioned additional stabilisation service to deal with the non-urgent dental needs of patients, so that patients will become dentally fit and then not come back into urgent care. So we have found that commissioning the stabilisation sessions has been a bit more easier to encourage the workforce, as we do pay on a sessional rate for that service rather than the units of dental activity. So commissioning access for vulnerable groups, that remains a key priority for us, aimed at reducing inequalities, and we've made some really exciting progress here, which I'll come on to on one of the next slides. And in terms of procurement, so big positive news, we have just agreed a new dental procurement. And again, I'll touch on that on the next slide. So I also wanted to just mention around oral health improvement initiatives. So we continue to work really closely with our local authority colleagues to commission a series of oral health initiatives aimed at children, and we've just agreed to broaden that into care homes as well. So we've received really good feedback actually from one of the national programme managers this week, who emphasised that this was very unique in Devon and that other areas could learn from our approach taken to this. Okay, so next slide. So moving on to our progress against these key priorities. So we have increased the minimum rate for dental activity delivered within the contract. So this has been uplifted to £34.66 from the nationally mandated minimum, which was £28. So quite considerably above that, and much closer to the £35, which was the recommended value by the British Dental Association. So increasing this rate was some of the strongest feedback that we had from our local dental committee and other stakeholders that was impacting on the recruitment and retention, and in turn access to patients. So we will keep this under review to ensure that Devon has competitive rates. Okay, so urgent dental care. We have issued a local incentive scheme in Q1 of this year. We've improved the rate of pay for delivering urgent care, which is now £105, which was around £40 before this. So that's a total investment of around £5 million into Devon, and that's to try and stimulate the market and increase urgent dental care activity. So we have 6 providers in Plymouth. We're also reviewing our helpline provision across Devon to try and improve access and make sure that there's seamless access for patients into those appointments through our helplines and through 111. And we're continuing to work with local dentists to encourage uptake of this service. So in terms of contract management, we've been working closely with the commissioning hub, who manage the contracts on our behalf, to rebase contracted activity to achievable levels. So that has freed up funding for us to commission new services. So last year we released 2.6 million from contracts in Plymouth that were not being delivered. So in essence, that funding was tied up in contracts that would underspend and then would not be deployable on a long-term basis. So that has now been released so that we can now commission those services. So this year we've also commissioned additional orthodontics activity. So that's 9,500 units across Devon and 1,235 of that is in Plymouth. And moving on to procurement, so big positive news. We have agreed a new dental procurement for dental activity, which will be split between urgent dental care, stabilisation and mandatory dental services, aimed at serving those most vulnerable populations. So this was released to the market on Tuesday, and Plymouth has the largest lot within this procurement, and we're looking for 54,000 units of dental activity per annum. And that's a contract value of £18 million across the life of that contract and 2.2 million per annum. So we held a market engagement event in August, and early indications are that there is interest across all of Devon lots, which is really positive. So we're looking to award those contracts in January 26 and for them to mobilise by the 1st of May 26. Okay, in terms of vulnerable groups, we continue to expand our commissioning services for vulnerable groups. We currently have a commissioned service for people experiencing homelessness in Plymouth, and we are working with public health colleagues to review the current needs of vulnerable populations, which may include us expanding the existing services and procurement of new services. So we're looking to complete that work this year and have wider services in place in 2026. Depending on the timelines around procurement processes. So we have also commissioned a service specifically for children looked after in Plymouth, and work is ongoing to support other vulnerable groups such as patients, a cancer pathway, and those under the bone strengthening medication services where patients may be particularly vulnerable to requiring dental support. So in terms of paediatrics, we're working with the Acute Trust community and general dental practices on how we can improve access for children at all levels. So currently we're undertaking a service review and we're working collaboratively with Cornwall ICB to agree a strategic direction and develop priority actions for going forward. In terms of workforce, we have invested 327k into Golden Hello scheme for Devon. This is where dentists are offered a cash incentive of £20,000 to take up a role in Devon, and in return they agree to deliver a minimum amount of NHS activity for a minimum 3-year period. So far we have had 4 appointments in Devon and we have 1 application pending in Plymouth. And we have also set up a workforce group which has agreed 6 initial areas of focus. Okay, so the next few slides just cover some of the activity data and measures that we're looking at to monitor the performance. So Devon, we currently hold 150 NHS dental contracts and 13 orthodontic contracts. So the ICB target, and as part of the NHS planning indicators for Q1 was to deliver 240,000 appointments, and we actually delivered 211 in Q1, so that was around 87% of the target. The ICB target for Q2 was 247,000 appointments, or around 82,000 per month, and the actual delivered in July was 75,000, so we're at about 91% of that target. So just to note, the June and July data is still being finalised due to the claim window, so that may increase. And we're working with our business intelligence colleagues to break down this data further by local authority. So hopefully we'll be able to provide more Plymouth-focused data in the future. So this graph shows the unique patients seen by a dentist over 12 and 24 months. So this dates back to January 20, so it's showing a 5-year trend. So I think children are the blue line. So children access in the last 12 months, I think you can see that it dipped during COVID, made some recovery and then has remained fairly constant. The adults line, which is the green line, again, that we had a dip during COVID, some recovery made, but then has continued to decline. So I think it's fair to say that activity in Devon has not bounced back following COVID, like some of the other areas, such as London. It has been harder in the southwest, particularly around rural and coastal areas, and it is going to take some time to reverse this trend. I think we are doing what we can in terms of commissioning services and the work we have started around workforce. But I think what we are hearing from studies being done around in connection with the local dental school is that being able to attract the new workforce and for the workforce to stay in Devon is much wider than what we can influence in isolation in the NHS. So students tend to want to go back to where they came from or appear to stay around some of the larger cities like London. So I guess wider thought there around what we can do to keep dentists in Devon and encourage local residents to take up dentistry as a career. So the next key metrics for the ICB is urgent dental care. So that's our main priority as a team, is to deliver the 81,705, which is our share of the 700,000 urgent dental care appointments in 25-26. That represents a 42% increase from when the baseline data was taken in 2023. There has been continued decline in urgent dental care delivery over the last 5 years. Since 1920, the activity dropped by around 5%. And then in 23-24, it was a 17% drop, followed by a further decline in 24-25 of 24%. So reversing this trend is the top priority for the team, and we continue to explore all additional commissioning options to run in parallel with our current urgent dental care incentive scheme. So our incentive scheme is one of the most attractive in the country. However, the disparity in compensation available for providers between NHS and private remains an issue. So this is the current performance across Devon. So we achieved 73% of the year-to-date national target. So the dark purple line on that graph is actual activity. The grey line is our national target. The grey dotted line is where we have forecasted activity based on previous year's baseline, and then adding on the national target. And then the purple dotted line is our forecast plus the additional activity which our providers have said that they can do following the expression of interest. So at the point of July, we were above our forecast. In August, we have included the August data here, but the claim window is still open. So this is only the first cut of data. So given the holiday period, we would expect this to increase and confident that that will follow the forecasted line. So I think the key takeaway from this slide is that whilst we may not be delivering the additional national urgent care target at this moment, we are beginning to reverse the trend in decline and maintain performance in line with our forecast, which will be an increased capacity based on the 24-25 data. And also, I think where we are in the national ranking, so we started off at 41 in the ICB's ranking, and we're now 31. So we are showing some consistent improvement there in our ranking nationally. Okay, so I think that was all I was going to say, but happy to take any questions from that.
Thank you very much. Patrick, you will start.
Thank you very much, Chair, and thank you, Melissa and team for a very informative update. And I welcome very much the partnership focus on dental health in Devon, but in Plymouth in particular, because it's an acute area where there's much concern from residents. I think it just underlines really the impact that the contract over a number of years has had to decimate really in many ways the National Health Service dental system that we've had. And you're trying as professionals to obviously work in a difficult environment to try and recover. And I welcome very much the government's commitment to reform of the contract, because ultimately, from my experience talking to dentists, it just doesn't pay to be an NHS dentist. So the whole ethos of providing sort of NHS services has been lost on previous governments in relation to properly funding it. So hopefully we will get a contract that creates a sustainable framework that you can work towards. And I very much welcome the release of resources from those existing contracts that have been reinvested. You mentioned the £2.6 million. That's excellent news. Could I have an assurance, though, that generally where underspending does occur, that there is the ability to reinvest it in dental healthcare in Devon and in Plymouth in particular? Because as a predecessor to Councillor Aspinall, a number of years ago, we were handing money back to the government rather than being able to spend it. So excellent progress being made, and congratulations to all those who are involved in trying to improve the picture. And certainly you've improved it in many respects. But can we be assured that where government is making finance available for spend in Plymouth and Devon as a whole, that we are actually spending all that money and not, as we were, handing money back? Thank you.
Who wants to take that one? Peter?
I feel that probably sits with me, Chair. Councillor, as you would expect, it is a difficult question to answer in entirety. What I can say on behalf of Devon ICB is that there are no schemes that we are exploring that offer value for money and improved access to our population that can't be funded because of lack of resource. So we are exploring every option to increase activity that offers value for money.
Thank you very much. And one just final little point. So obviously when the public register for an NHS dentist, many assume it's on the same basis that you register. I know it isn't. It's the same way you register for a GP. So are we likely to see the potential revision of the dental contract take into account perhaps a level playing field, that the assumption that when you register a dentist, you won't be removed from it without your will, should you not use the dentist in a period of 2 years, which seems to be the period in which dentists seem to remove you from the list?
Peter, are you able to sort of comment about whether you'll argue?
I'm hoping that Matt's hand coming up is the cavalry coming over the hill for me.
That's all right, Peter. Mary, thank you. So I think this is an area where it's expectation of patients. I think it's a very strong indication across the whole of the country that patients feel that they are registered with a dentist, and we've taken that back to the national team for some guidance and advice on actually addressing that issue, that patients aren't registered, they have access to a dentist. The guidance for seeing a dentist over a 2-year period is nice guidance, and it's been out for a number of years and it hasn't been followed. And some of the new reforms that are coming in April will address those issues, and hopefully will go towards then answering that question that patients can be seen but they're not registered with a dentist.
Thank you. Right, Andy?
Thank you very much. 2 questions. One is of a technical nature and the other is an observation on the finance. I mean, it is absolutely alarming that there's still remains a massive decline in urgent dental care. Now, I see the UDA uplift, but surely those figures just bring us up to what the national level is at present. How will this make an impact on reducing this? I acknowledge, as Councillor Nicholson, that there's been an actual situation where things have got better, and I applaud that, but I need some assurance that monies are best applied to driving it down. The issue also with the dental point, the technical point, the fluoride treatment that's used for children, which again is commendable, it does prevent a lot of future damage. But can we have an assurance that if this treatment's applied, and it's applied without a dental checkup, that it doesn't simply mask over massive cavities which could cause problems by the masking over of the fluorine varnish? So technical question and general observation question, please. Thank you.
Peter, shall I take the technical question first? Yeah. So the fluoride, you've got a number of fluoride measures, and I mean the supervised toothbrushing is the one that I think is going to be the most
beneficial to look at prevention, and that's been evidence-based, that you won't see the evidence of that for 2 years, but there is definite indications, and that's public health papers that support that by doing that you will see a prevention of decay. So fluoride application won't in effect mask dental decay, and the priority of Devon ICB and across the region is obviously bringing access to children so that they have the opportunity to see a dentist to make that assessment. So the prevention element will go towards preventing decay and giving those good measures to support the younger population. Topical fluoride in the right indication is also a good measure, but actually the priority of the ICB should be to see patients that need that. And as I say, the level of patients and access hasn't changed. There'll be a number of patients that are seen privately, and it's about addressing those patients that can't be seen or haven't got access to a dentist. And I think they're the measures that the ICB are actively working on with paediatric review across Devon and Cornwall as well. So I take on board what you say, but the prevention element is crucial, and that is definitely well evidenced.
And I think to your second point, Councillor, I think what I heard you ask is for assurance that there are sufficient resources being directed towards improvements in this area if it provides benefit and value for money. If I misunderstood the question, then please restate it.
Yes, please.
Yeah. So again, I refer you back to my previous answer, which is money is not the limitation in the schemes that we're exploring, but clearly we have to provide value for money in any of the schemes that we introduce into the system. So at the moment, the limitation is around workforce availability and appetite, as we've discussed already.
Just coming back on the technical point, if you indulge me a little bit further, I think I probably phrased the question in an incorrect way. When I read the slide, it says to create a new course of treatment for the application of a fluoride varnish. I hear about preventative measures introducing fluorine generally, but the fluoride varnish to me suggests something which is applied to children, according to this, without a full dental checkup, and which can be applied by an extended duty dental nurse between full checkups. The point I'm trying to drive home is, if this is a highly dense fluoride varnish that's been applied to children without a dental checkup, and there's an underlying cavity there, it's almost like bleaching teeth where there's a fracture. Surely that's a medical issue, which is a big problem. This works. Thank you.
So the fluoride application and using the dental team, the wider dental team, is after an assessment. So yes, you're right. You won't be just placing fluoride varnish in a school setting without actually a dental assessment. You're absolutely right. So sorry, I misinterpreted the question. But prevention and use of fluoride is, and so the supervised toothbrushing, etc. Those elements don't require an assessment, but the application of fluoride, which is concentrated, does.
Thank you. Right, Jemima.
Thank you. I think it's really positive to read this, actually. For a long time of kind of shouting about dentistry and problems with dentistry, it's, there's real significant improvements in here. But I wondered if I was going to describe it to a resident, what all this means to them. Does it mean that they can sign up for a dentist where they couldn't? Will it affect the waiting list? And I think some of the improvements. I think there's a problem of a kind of self-fulfilling prophecy for some people who will never even bother ringing a dentist now, because they, the received wisdom is you can't get one and you can't see one. So I wondered about how some of these improvements are being communicated to the public. So it's two things really. What if I'm going canvassing later on, and if dentistry comes up, how can I encapsulate this for them, what it means to them, and how are we communicating some of this, significant improvement in money and resource coming into dentistry in Plymouth? And then I've got another question, but I'll wait my turn.
can I answer that, Peter, first? Is that
Yes,
right?
please.
Yeah. So I think that is I think that's a regional responsibility for communication and to the wider public, not only to Devon and Plymouth. And that's something that certainly we are looking with comms teams in those messages to go out to the population. Regarding urgent care, which is obviously a priority, there has been some comms nationally to support that as well. But actually, it's about the capacity of the urgent care appointments and patients accessing. So it is a difficult balance, because what you don't want to do is put a lot of messages out, and then suddenly those patients then struggle then to get the access to the urgent care appointment or the stabilisation appointment to support them, and then create a complaint or an MP query. And so actually, by working with the ICBs and delivering those messages as and when those things that Melissa has talked about that come online, then those public messages can increase. And I think it's really important to know that we as a region have pushed back as a national team to say actually that some of these messages need to come from government about expectations of accessing dentistry, as well as that the population, not everyone in the population can have access. So those are constant things that we do push back to government as well.
Peter, did you want to come in?
No, I think that Matt's answered. I think the engagement is really important, but there is a danger of there's always that danger of local versus regional versus national engagement becoming muddied. So I think there is more work for us to consider. And I think as we start to introduce, we've heard a lot today about our aspirations around neighbourhoods. I think that will be the place that we start to be able to nuance communications that mean something directly to our citizens.
Thank you. And certainly from my perspective, we've got the statistics that Devon currently hold 150 NHS dentistry contracts and 13 orthodontic contracts. Can we get that broken down to what you're doing in Plymouth? That would be really, really helpful. Thank you. Gary.
Councillor Lang put me to it, that question around public messaging, really, which for me is really, really important. And I think probably we saw a lot of creativity and hard work that's going on to improve things. I just don't think it covers that area. And that would have been my request with that piece of, we will know in Plymouth the places we want to land those messages most. And if I'm sure that's the same for Devon. And my request would be, can we get it down to that level? So when there is a scheme in Plymouth that's going to make a difference, that we are really targeting to make sure that then is used by the people we need it to be useful most. Thank you.
Thank you. I think we make note of that in the recommendations there. Joanna.
My second question is about removals under general anaesthetic at the hospital for children. And I know that there's a fixed number of slots and that those get filled and those amount of teeth get taken out. And I wondered what conversations were being had around resource because we know there's a huge number of children who don't get onto that slot. And given all this kind of resource coming in, I wondered whether there were conversations around increasing the number of slots to get those children that are still waiting to have their teeth removed.
Rachel, is that something you can take?
So we proceeded to work out the governance of things that are going through the dental task force and coming through here, so we just make sure that's aligned. So we regularly report through the DAs. You're absolutely right, we've seen both the numbers, so the demand, the need for teeth extraction increase considerably, and the number of teeth that are extracted remains a considerable concern. At the moment, that is uplifted by growth, so kind of 2 to 3% each year, but we are at the moment just looking at an internal business case to increase our dental capacity because of the concern we've got around waiting times and meeting the national standard and the impact for those young people living with that. So I think if you can just give us a month, so probably the next task force will have taken that through, but that will need to be some internal risks that we take to do that, but we think it's important given the needs of the children.
Mary, can I just add to that the Devon, ICB and Plymouth are actively trying to look at a paediatric consultant, which across the region, we only have a paediatric service in Bristol. And as a region, we're looking at a fragile service review of all our dental services, and I think make no shape that paediatrics will be part of that fragile service return. But welcome the Derriford and Plymouth in looking at that paediatric consultant, which regionally we are working with the managed clinical network in paediatrics supporting Derriford. So that will actually help then longer term with workforce and obviously the management of these patients, GA being one part of it.
Thank you. Jemima?
On the recruitment and retention question, what are other places doing well? You know, in terms of, I take the point about students might want to go back to the place that they came from and just came here to study or whatever, but what are there some tricks we're missing? Or I mean, I'm sure everybody puts their mind to this all the time, but how can we make it more attractive to persuade students to stay here and to recruit, you know, qualified dentists from all over the place? Is there a model of good practice somewhere that's doing it really well that we can just nick their ideas, I suppose, is what I'm saying.
I think also, have we got sufficient dentists in Plymouth that will take on that postgraduate 12 months that they've got to do with the surgery? So it's, have we got those, if you want to call them tutors or whatever, I don't actually know the correct name for them, but that year that they have to do in clinical practice before they're let loose?
So dental foundation training numbers are, don't quote me, I think we're on about 86, but around that number. Recently, we've just appointed a new postgraduate dental dean to the Southwest, Craig Barkley, who has actually works for the other part of the week in Manchester, so has actually come into the region with a number of ideas and plans, workforce being obviously the priority. And both Craig and myself are regionally working towards in exactly doing that, improving the workforce. It is a longer term plan, can't just suddenly make those changes, but absolutely there are things that we can do at pace. I think one of the other areas that is really keen to work on is apprenticeships. So looking at nursing and the wider dental team to develop those apprenticeships at a local level, which will actually help. And I think also, going on to what can we do in the region, there has been some discussions about providing some marketing and videos to go towards in showing the benefits of working in Devon and the wider parts of the Southwest. And I know that Melissa and myself have had conversations with Ian Froome, one of the MPs in North Devon, which is quite keen to develop that. So there are things happening. I think we're working towards it.
Well, can I just put a plug in for our new branding work, because there's a very good video and a whole load of assets around what life is like in Plymouth, and if you don't know about that, it might be useful for you to know to share.
Yeah, we can certainly make sure that is Ellie dealing with it, or who would be the contact in PCC?
Amanda Lumley from Destination.
Yeah, so that's good. We'll make sure that you get that details of Amanda. Okay, folks. Right. Well, thank you all very much for that. Let's hope when time we have the next report that we've got more dentists arriving in Plymouth and prepared to do NHS work. That would be really, really wonderful. So the recommendation is that the Health and Wellbeing Board review, comment and debate the contents of the report, its implications and the next steps for board partners. Are we happy with that? Yeah. And I think we've accepted that if we need to call an extra meeting anytime, we can do that. Thank you very much indeed for that, Matt. It was good to see you again. I will now move us on to the next. Oh, can I have a vote on that? Everybody happy? Yeah, excellent. Move on to the next item, which is Plymouth Drugs Partnership Annual Report. Welcome, Kamal and Jane. Nice to see you both.
Thank you, Chair. Yes, so I'm Kamal Patel. I'm a consultant in public health in Plymouth City Council.
Yeah, hi everyone. I'm Jane Marley. I'm a public health specialist in the team. Nice to meet you all.
And yes, so we're here to present the annual report for 2024-25 of the Plymouth Drugs Strategic Partnership. So the full report is in the pack, and I'm going to go through some slides. And they come up on the screen. Okay. Right. So just a bit of background to the work. So we all know that there's significant individual and societal harm associated with drug and alcohol dependence. And people who suffer from drug and alcohol dependence often have coexisting significant challenges in their life, including poor physical and mental health, discrimination, poverty, exposure to violence, offending, and homelessness. We also know that drug deaths in England have been rising since 2014, and that led to the National Drug Strategy in 2021, which kind of had three main priorities to that strategy, bringing together health and enforcement aspects to break the supply chains, deliver world-class treatment and recovery, and achieve a generational shift in demand. And that is the work of the Plymouth Drugs Partnership. So the partnership is made up of multiple members, as you would expect, from Public Health, Devon and Cornwall Police, from regional teams in OHID, the providers in the city, probation services. I'm trying to read it. It's very small. Safer Plymouth, and the Police and Crime Commissioner, and also elected members. So the need that the partnership is addressing is shown here. So we have estimates on drug use in Plymouth. These are provided nationally based on research data and applied to populations. So we have the estimates that there are about 2,000 people in Plymouth who use opiates and/or crack. There's a breakdown there, and about 3,500 people who are alcohol dependent. Compared to England, we know that the rate of people who use opiates and crack is about 27% higher, and our alcohol dependency rate is 21% higher. In terms of drug treatment support, the main commission providers are through the Plymouth Alliance for Complex Lives, and there's Harbour, Hammers House, and Live Well South West for adult services, and for young people services, the Children's Society are a commissioned service. So I'm going to present some data on drug treatment over the last year. So in terms of capacity in our drug treatment service, we've seen an overall 8% increase in capacity. As you can see there, it's mostly stable. The increases are driven by people who are entering treatment for non-opiates and alcohol, and non-opiates only. So that includes things like ketamine, for example, and just a couple of extra points to highlight on there. Also, sort of large increases in people who have used crack as well. In terms of the reductions there, the children and young people's 12% reduction. We've interrogated that data, and it's most likely due to change in provider in that time and a miscode when people were transferred across from one provider to the new provider in the commission service, and that was coded as having left service rather than transferred. So that has been addressed, and the actual numbers don't show that, but I'm presenting the kind of official figures here. So unmet need. So this is the percentage of the estimated prevalence of people who use a specific substance who are not receiving treatment. So they're the unmet needs. So in this case, lower is better. As you can see here, and it's consistent over time from previous presentations I've given to the board, our unmet need for opiates and crack is significantly below the national average, despite having a higher prevalence in Plymouth. So that's a really important thing to note. There, actually, our unmet need for opiates and crack is one of the lowest in the country. So we are really good at reaching, even though there are 37% of people who use opiates and crack who are not in services, It's one of the top 5 in the country for that. For alcohol, as you can see there, significant unmet need across the whole country. 76% of people in the whole country not in services, and in Plymouth that's 79, so slightly above there, and I'll go into some of the work around alcohol later. Treatment progress, that's a measure of how successful the treatment progress has been. So the top there just outlines the adults. So overall we have 47% of people in our service who either complete service successfully, are drug-free in treatment, or a sustained reduction in drug use, and that's the same as England. In terms of children and young people's outcomes, this shows the proportion of people who are still using the substance that they entered service for after their treatment, and it's quite similar to the England average in Plymouth, but actually we're below for those for cannabis and other drugs, and our unmet need for mental health is also lower than the England average. Continuity of care, so this is prison leavers who have a drug treatment need. We know that they have a higher risk of harm, death and reoffending if they have a drug treatment need, and that risk is reduced by good continuity care into community services on discharge from Plymouth, from discharge from prison. And as you can see there, it was one area of our work that was relatively poor previously, but in the last year we've had a significant increase in that pickup rate, and there's been lots of work in that area to have figures that for the year 24-25 matched the England average. We've now gone slightly above actually at the current moment in time, but yeah, that's been a really positive story as well. Moving on to drug deaths. So drug misuse deaths uses coroner's data, so that's why the year is 2021 to 23 because of the registration data. So that's the most up to date we have. So we have drug deaths in Plymouth 7.5 per 100,000 and 5.5 in England. Proportion of that will be due to the high prevalence of drug use in Plymouth compared to England. And next, the graph shows deaths in treatment. So that's a death of any cause from someone who is in drug treatment. So it doesn't matter what caused death. And again, we are above the England average for that. As you can see in the year, we've come down significantly towards the England average, and the year before that we were even higher at 1.89%. So over time, you're seeing a trend coming down towards the England average, which is stable over the last year. Alcohol deaths is something where we've seen an increase in alcohol deaths over the last year in Plymouth, whereas nationally there has been a reduction. It is important to say that the confidence intervals for this, for the two Plymouth years comparing each other, overlap significantly, and comparing Plymouth to England overlap significantly. So I have to take it with a pinch of salt, but there is clearly we want to see that coming down, and there is, like I said, I'll outline the work that is going on around alcohol in a minute as part of the delivery plan. So all drug partnerships have a delivery plan, and I'll outline the kind of elements of that next. So improving the quality and capacity of drug treatment services. I've talked about the capacity of drug treatment services in terms of quality. The Alliance have a treatment subgroup, a drug treatment subgroup, and an action plan following these 8 priorities. And there's significant work going on in each of those areas, and this was co-designed with providers and people who use services. In terms of reducing drug deaths, this follows multiple areas of work. So we have a Plymouth local drug information system to monitor drug harms from potentially new or novel or contaminated drugs and respond to that appropriately with appropriate communications and actions. We have a synthetic opioid response preparedness plan. We have peer-to-peer naloxone. So naloxone is the drug that you can give to people who have had an opiate overdose to reverse that overdose. And the peer-to-peer program has significantly expanded the reach of that. We also have a Plymouth overdose response team, so a specific team that look at people who have had an overdose, because we know that a non-fatal overdose, because we know that in their 28 days following that, they are at high risk of a fatal overdose. And so this team get the information on non-fatal overdoses in hostels and provide that wraparound support, including rapid access to prescribing of opiate substitution therapy. And we also have an avoidable deaths review group that reviews deaths by deaths related to drug and alcohol. So the death can be any cause, for example, suicide or drug and alcohol related deaths because of the overlap between those. But where drug and alcohol is a factor in that person's life, that the group can review that and highlight areas of learning. I mentioned alcohol a few times, so we have an alcohol steering group. An alcohol needs assessment is currently underway. We have a new specialist community alcohol treatment team at Harbour, and a dedicated alcohol training package is being rolled out around kind of brief interventions and assessments so that the right people can be referred. We're working with licensing teams as well to manage kind of availability when there are license applications for alcohol premises. I talked about screening tool. We're strengthening our referral routes from hospitals, developing audit standards, and finally we're also implementing a program where we're offering intramuscular thiamine for people with alcohol dependency, which is a protective to protect from alcohol-related brain injury as a result of their alcohol use. So the headings here are the different elements of the delivery plan. So workforce is a really key priority of the treatment subgroup. We have a workforce development coordinator in place working on various approaches, including suicide prevention training, trauma-informed approaches. We're implementing workplace wellbeing champions within our drug treatment providers as well, and embedding the drug and alcohol capability framework into the Alliance. This outlines the integration of services, including mental health services, accommodation and employment. So we have a really robust mental health offer in Live Well, which sit in Harbour. The complex needs Live Well team sit in Harbour, so they're co-located. And this they contribute to MDTs, provides clinical supervision, improved access to psychological therapies and trauma stabilisation. We work closely with the Health Inclusion Pathway Plymouth, or HIP, who are doing also great work in this area. Our drug treatment team do drop-ins at our hostels. We have a specific homeless intervention team, and we also have the individual placement and support work at Shekinah, which have access to employment for people using their services. Criminal justice elements, I've talked about the continuity of care improvements in the year, and that's due to the strategic coordinating group, which have done kind of work in these areas. So in reach into hospitals, working specifically on alcohol, work involving self-assessment tools, and also including work with probation. So children and young peoples and prevention. So we're seeing increasing the work that we're doing is seeing increasing referrals from schools, which is a good thing because that's supporting them. There's a really strong link to CAMS, so the mental health service within our drug treatment provider in the young people. So we have an embedded CAMS worker within there to support young people. The zone are providing educational sessions to secondary schools. And then we have a specific partnership set up to support young people and educational settings. It started off as specifically looking at vaping of substances controlled under the Misuse of Drugs Act. But that's now expanding that young people's group into kind of all young people's needs and looking at different elements of that. So that's the work group that's outlined there. Looking at launching the drug use screening tool. We're understanding ketamine through a task and finish group, and looking at implementing a virtual team model of all the different elements of the city that support young people. So youth workers, the drug service, CAMS, there's different elements that support people so they can work better and coordinate that care. And then just finally, looking forward to next year. the priorities going forward are one of the things we are doing is, as I mentioned at the beginning, the drug strategy talks about enforcement aspects and bringing those things together. That's been one of the challenges of the drugs partnership, because partly because the footprint of the police is different from the footprint of the treatment services. And so we're looking to actually combine our work in that strategic drug enforcement space across Devon and or Cornwall, that says, because Cornwall haven't decided whether they want to join yet. But that will allow better coordination of work with the police going forward. We are going to refresh our delivery plan of the drugs partnership. So comments from the board around elements to work on there will be useful. We're undertaking a health needs assessment for substance use. We're going to continue to build on the Children and Young People's Working Group, which is relatively new but a really important piece of work. Continue to work on synthetic opioid preparedness because it's a continuing challenge. And then finally, co-production, really strengthen those co-production approaches with people who use services to make sure that we are meeting their needs, and a working group has been set up already, or setting up for that. That's it. I will stop sharing.
Jane, is there anything you want to come in on there?
No, I'm here in an observational role, Marion, to help answer any questions. But
thank you. Right, any questions? Andy?
Thank you, Mary. Yes, excellent report and some positive steps. Quick question regarding working with licensees on applications when it comes to combating alcohol abuse. Can you tell me a little bit more about the programme? Because, of course, every licensee who makes an application to this authority needs to comply with the licensing objectives. Are you suggesting that there's something over and above that which they need to deal with, please?
so at the moment, we're going to be joining the public health. We're going to be joining the panel in order to assess applications. So that's kind of what we're looking at the first stage, because one of the areas of work that has been done and has been led by the consultant hepatologist at the hospital, and has kind of engaged public health in this work, is that they've kind of mapped out areas where there are lots of kind of licenses for alcohol, and the kind of numbers of people kind of coming into hospital who require help around alcohol against that. So there's kind of a bit of research going on around that, but then also kind of in public health, we're going to form part of the panel to kind of look at those applications, just so that we can kind of make sure that people who are experiencing alcohol dependence, you know, that we're not kind of, there are already lots of places with licenses, I suppose, existing selling alcohol. So it's just kind of reviewing whether we kind of need more in those areas, or kind of whether there's any work that we can do around harm reduction to prevent kind of high strength alcohol also being sold in those settings. And that's a piece of work that the police have been doing for quite a while. I think it's called Reduce the Strength, that campaign that the police do to make sure that they kind of go into those licensed settings and then talk to the owners of those premises around high strength alcohol that's being sold there, and kind of maybe the benefits of not selling those high strength.
It's a point of clarification, and Steve might be able to help with this. I mean, public health are a consultee in a new application in any event. Are you saying that this is now your team is wider participation as a consultee? Presumably you're widening out the consultation bit, for want of a better word.
I think it's just that we're moving into a more proactive space with it, Councillor. I think, yes, you're right, we've always been a consultee, but I think highlighting the damage that alcohol does across Plymouth, I think we recognise the need, as highlighted through the report, that we need to be more proactively engaged in that space.
But didn't you go to one of the organisations that were working with children? Or have I missed that?
I attended an Alcoholics Anonymous meeting. Yeah, I was invited to Alcoholics Anonymous to see their work, and they talked to me a bit about the younger people that they are working with.
Sure.
And actually, sorry, they wanted to, apologies, Rachel, apologies, Chair. They wanted to do more to promote the fact that they work with younger people, as well as what people might traditionally think might be the person that engages with them.
Thank you, Chair. Kamal, an excellent report, really clear to read, and I think really gets to the heart of the areas that we want to make improvements for really what's a really vulnerable community. I guess the bit that strikes me is still where we sit in terms of deaths in treatment and compared to the national average. And I just wondered whether from any quality reviews or deep dives that we've done around, is there anything that we're missing in terms of things that we could have done better to prevent that for those individuals. And I think this is one of the service areas for health and wellbeing which all of us have a contribution to make, both at the prevention right across the services. We're due to launch our Complex Lives Hub within the hospital. We have seen increasing numbers of attendees through a range of substance abuse and drug use, and really bringing partners. We met with Plymouth Alliance last week in partnership with Live Well to really help support the kind of colliding needs that individuals have that can lead to then some of the complexity that they're seeing. So it'd be good to join up outside of that to make sure if there are any themes out of those deaths or other quality pathways that we're learning from them, and how can we see what we can do differently.
Absolutely, yeah, thank you for those comments, and 100% echo those. So I think in terms of deaths in treatment, a couple of things regarding the data. So firstly, we, as I mentioned before, we are coming down over time. So 2 or 3 years ago at 2% compared to nationally at 1.3%, and now at 1.5% compared to 1.3%. So yeah, still a way to go, but it has been reducing quite significantly over time. So that's really promising. And lots of that is to do with the work that kind of outlined there. So I think, and the other aspect of that data is that not entirely attributable, but some attribution to the fact that we know that our treatment cohorts, the people in our drug treatment service, are generally slightly older and more complex than the national average when you look at kind of polydrug use and their age. And so by naturally, that will also result in a higher deaths in treatment result, but it's not just a data thing. So the avoidable deaths review group is a really important aspect of this. It's only been going on for about a year now, and it looks at 2 deaths every 8 weeks in detail and gets kind of information from partners that are involved in that care, including people in treatment and not in treatment, because there's things to be learning across the board. But it's the system learning from that that's going to be pulled together actually into a separate report and taken out as well. So that will be shared widely as well. And the learning and you know, some of the things will be new to people around coordination of care, communication, around outreach. You know, there's lots of things like that. But I won't speak in advance too much now. But that's the work that's going on to address that. Yeah.
Thank you. Anybody else with a question? No.
I just got one from screen, Councillor Aspinall, if that's okay.
Yes, certainly.
Sorry. Kamal, I just wondered what work we're doing in relation to some of our most vulnerable children and young people. Particularly, I'm thinking of care experience, care leavers, and the YJS cohort.
Yes. So Dave Swartz is leading the work with the young people's area, and they're a part of. So he's linking in with the various parts of the children's system in order to make sure that we're addressing that need. So it's through the membership of that steering group, and I will check the membership. I know Youth Justice are involved, but I will check around kind of care leavers and children in care as well to make sure that's represented.
Okay, thanks. And I can follow up with you
Yeah.
after, as is helpful with that. Thanks.
Thank you.
Oh, sorry, just a point of accuracy. You did correct the data that you'd presented, and I just wondered if that has been corrected within the fuller report or a footnote in terms of the children's data, where the data presented, you've yes. questioned the validity of it, and because it's showing a less strong picture.
Yes.
Have we made sure that people are aware of that when they read the data?
Yeah, so I've written it as a narrative in the report. The official data hasn't changed because that is what was coded in that year, and you can't go back to change that. But I've written as a narrative there,
Okay.
and the problem has been addressed for the future. Yeah.
Yeah, great. Thank you. Thanks.
Okay, folks, the recommendations are that we endorse the action taken by the drug partnership for the year 2024 to 25. And if we want to, we can provide comments of suggested areas of focus for the partnership going forward. And I would suggest we put the care experienced young people into that focus, please. Anyone else want to add anything else to that? No? Right. So thank you very much indeed, Kamal, for coming along. We're all happy with those suggestions. No voting against. Good. Thank you very much, and we'll keep in touch, no doubt. Thank you. Right, now we come to one of those highlights of our sessions, partners updates. Tanya, do you want to present yours, please?
I would. I'm afraid I don't know what the Wi-Fi password is to log in and share the slides we have.
Oh. That's a
that.
shame. Can you manage it, Elliot? Elliot will do that. So if we move then to Chris, if Chris wants to.
Through you, Chair, Chris has had to leave for a meeting. So.
Right. Okay. So we will get that from him. Perhaps get that written report from him. All right. For that.
Rachel.
Yeah. So Rachel.
Thank you, Jen. I'm conscious of time. So perhaps if I just pull out three kind of key areas that I'd like to showcase on behalf of the Trust today, but very happy on any items I don't mention to take any questions. Since the committee last met, that you will have seen that nationally they published the National Oversight Framework for all NHS trusts, which serves to both rank and provide a rating of how those are performing against both operational, quality, staff and financial indicators. So those range from one being of the highest quality, if you put it that way, and five, which would have segment 5, which is what we previously knew as kind of special measures as a guide to members. And UHP were regarded as being in segment 4. So clearly not where we would want to be, but you will see that has moved up from we probably in old money would have been in a segment 5 with the National Support Framework. So from the improvements we've made, we are moving up that segmentation. Just to put this in a bit of context, if any system it has a financial deficit, they are unable to score above a segment 3. So 4 or 3 would have broadly been where we landed until that financial recovery is met. And largely, for to be transparent, the areas that have led to that segment 4 rating has been our ambulance handover, which we've talked before, and I think if we continue to be remeasured, we'll see increasing progress on that. Our annual scoring on people's experience of training and placements with us, our staff survey, which we're out at the moment in terms of getting feedback, and we are encouraging people to share their feedback with us. It's really important that we know, and we do that through just one mechanism, but that's a critical part of this scoring. So just in terms of what we're doing, this is a very open framework. I talk to the public, so it's a really important conversation we've had with our teams that this is how our public see the rating of the hospital, and that isn't really how we want to be judged. There's so much more compassionate care that we're providing, and we rank 109 out of 134 trusts overall, which reflects the kind of segment 4. We clearly monitor those indicators and are part of our overall improvement plan, and we will report in quarterly our process against those segments through our trust board each quarter. The second area I wanted to talk to you about at a very early stage in light of our engagement and co-design, we've been invited to bid as an organisation for an extension to our CDC that we're currently building in the city centre. We're one of the only bid in the southwest that is going forward. I'm leaving here to go back and sign the pen on the final submission later today. There is no funding guaranteed at the moment. I need to make that clear from the national team, but essentially we would be looking for a capital build of between 20 and 25 million as an extension to that facility, but are already starting the co-design with Gary and your planning team to think about how this could be the start of what we're calling a kind of a community, a health community, thinking about some of the other exciting developments that we've got in the city about the need for housing, the ongoing conversations we've been having with Live Well and the ICB about possible dental relocation and primary care relocation in and around that start. So if you can bear with us while we do that design and bring that together, it's a very early stage, I would say, but we didn't want to miss the opportunity to try and secure an asset and expansion in the city centre. And broadly, that would enable us to, we were looking at additional pathways for one-stop care, cancer pathways, and increasing the range of diagnostics that we would bring into that. Really important for our deprived community and our P1 population that we know find access to dairy food particularly difficult. The third area is delighted to report that our surgery services have recently been rated as good following a CQC inspection. They were previously required as inadequate and have moved up into the good category. That has been on the basis of a significant improvement work across our surgery team, and my thanks to them and our professionals who've continued to make improvements in safety experience and access to care. And some of our new facilities that Mary's visited, our Big Bree Orthopaedic Centre, the REI is a key contribution to that too. And then finally, to share some news around our stroke performance. You'll be aware in the Peninsula we are the lead stroke provider for thrombectomy, really important part of the care we can provide to people with stroke that leads to quite significant outcomes, improving their condition. In the 24-25 annual report, the SNAP report, we've ranked second in the country, and that only just picked in terms of by one of the London Trusts. That's a significant achievement in both the quality of those standards and the access rate to thrombectomy that we're now providing, and we're going even further with the rota work that we're doing and the consultant expansions that we're making within the trust. So we'll continue to aim for that #1 spot in 25-26. There's other things in the report, Chair, but for conscious of time, if they I've missed, please do feel free to ask a question. Thank you for the opportunity to share that.
Thank you very much for that, and certainly going up yesterday for the opening, or technically I suppose it was, of the new Dartmoor building. I mean, it's going to be fantastic. You won't know yourselves going up there. It's really good, and certainly a lot of positivity about that. Thank you for that. Patrick.
Thanks, Joe. Thank you, Rachel, for the update. And very welcomed, I'm sure we speak on behalf of residents, of the upgrading of the rating for surgery services. So that's really good news. More parochial, but the sort of issue that we do get from residents is really the drop-off pick-up point, and the fact that obviously with the development at the front of the hospital site, the fact that people are standing out in the open without any sort of apparent shelters. I don't know if you just take away from this meeting and perhaps just look at whether there can be some shelter, particularly in the winter period, where effectively people that have to be picked up because they're not, they can't drive and they can't get on a bus, are just stood up in the open. And I've been up there many times, and it is quite exposed. The wind does drive across the front of the hospital. So if that could just be looked at, Rachel, that'd be very welcomed indeed.
Thank you very much for sharing that, and we're very grateful for our public and our professionals who are bearing with us with the development. You'll see the new crane that's arrived, which took my breath back, actually, I have to say, for the new one, but I absolutely talked to our estates team. Well, I think we're going to learn a bit, so please continue to give feedback, because you and your residents will see it through eyes that we may not always see. So I'll take that back and come back to you. Thank you.
Anyone else? No. Okay, thank you, Rachel, for that. I gather we've got your slides up, so the floor is yours.
Thank you, everyone. Yes, we wanted to let the board know about the DASH review and the future of Health Watch, give a bit of an update. So the DASH review was published in July 2025. The government has accepted all 9 recommendations in the review. The one relating to Health Watch was recommendation 5, which sets out that the statutory functions of Local Health Watch relating to healthcare should be combined with the ICB, and those statutory functions relating to social care should be merged in with local councils to improve commissioning of social care. it will require a change in the Health and Social Care Act to make these legislative changes. We're expecting that will be announced in the King's Speech in spring sometime. So what that means for Healthwatch is in the 10-year plan that was published from the NHS is it proposes to close Healthwatch, close Healthwatch England, or merge that within the Department of Health and Social Care, with a new National Directorate of Patient Experience. And then, as I just mentioned, local Healthwatch statutory role would be merged in either with NHS, the ICB, or within the social care functions of the council. In the meantime, from a Healthwatch perspective, it's business as usual. We have been told that contractual arrangements should be continued to be in place until these changes are made from like wider government legislation. Next slide, please. Locally, our current contract runs until March 2026, and we're waiting further information from our commissioners on what our contract will look like going forward. But until legislation changes, there is still a requirement to have an effective local health watch. Our engagement priorities are being kept under review as we work to look at where we can make the best difference and where patient voice really needs to be heard at the moment, given there is so much change across the landscape for patients in the community. We're in regular contact with NHS Devon around potential engagement in support of the 10-year plan. I think as Chris showed earlier, we were quite heavily involved in the initial community engagement to inform that. I think somebody mentioned about having children's voices. I think we were one of the only places in the country that managed to get a few actual children tell us what they thought about their thoughts on what the NHS could look for them. Our chair, Dr. Kevin Dixon, as I said, has stated it's business as usual and remain committed to hearing what local people think and feeding that back into services.
Yes, thank you very much for that. I think the abolition of Healthwatch became very much a surprise to all of us, I've got to say that. And certainly we will very carefully watch what happens next. Obviously it's saying that some of it will come into this adult social care, so we'll need to think how we blend that in, because you've built up a lot of expertise over the years, and I certainly have always valued your reports, so thank you. Any questions? Gary?
I guess I just wanted to respond to one point, because I mean, we would note the importance of getting the voices of people into everything, but around that business as usual, and I've just, in your slide, you talk about contracts up to 30. We need to make sure that we're all looking at that and giving the right assurances through whatever that transition looks like, because none of us really know yet what that looks like. But I guess it's just to echo that assurance that we, to be in that space and to continue to work with people through this time from me.
I suppose the other thing, of course, you use a lot of voluntary helpers, don't you, to get, and no doubt they are feeling a little bit dispirited. So hopefully we can make sure that their expertise is transferred, but we will watch this space.
Absolutely. Yes, our volunteers have been with us for a long time. They're very dedicated. They do quite a lot of work across the community. We have got a care home engagement program going at the moment. And they're also helping with the place inspections at Live Well this year. So yeah, again, a huge amount of resource there that hopefully we don't lose that local knowledge.
Thank you very much for that, much appreciated. And in fact, looking at our paperwork, of course, the ICB have sent some written stuff there. So if there's any questions that anybody wants to raise, we can note it and then get that information from Chris. Okay. Now I've got so many papers around here, I don't know what I'm doing next here. So from that, we just note those reports and thanks to everybody. Tracking decisions.
Thank you, Chair. 5 tracking decisions on the spreadsheet marked as complete for members. 1 on hold, which was requesting an update on the implications of the comprehensive spending review. That will be progressed as soon as the implications are known. But happy to take any questions. Thank you, Chair.
Lovely. Okay, everybody happy? We'll see where we go. Which brings us to the work programme. We've obviously got our 3rd of October meeting, so the next meeting is January. Probably too soon for how the winter stuff has gone through, but it might be quite useful if there is an update on flu injections and COVID injections, mightn't it, vaccinations?
Absolutely. Absolutely. I mean, we're monitoring these regularly, so we could send one of our weekly reports just to take stock of where we are at that point. No problem.
And that, if we say that we want something for that January meeting, it will cover those 2 weeks as well from the danger 2 weeks and Christmas, won't it? So that could be useful. We've got a revised health and wellbeing board in terms of reference and board's strategic plan that is supposed to be coming in January. So
Yeah, that will. So the terms of reference definitely can. Oh, sorry. The terms of reference definitely can do because we've redrafted those. I think we may need to have a further discussion in the January Health and Wellbeing Board about the strategic plan because it leans into a number of other conversations that are ongoing on at the moment in relation to a health plan for Plymouth, but also mindful that there is an ambition to refresh the Plymouth plan. And how those kind of dovetail into each other. So I think we'll spend the time pre-Christmas doing some exploration around that, and we'll bring something back for discussion in January either way.
Thank you. Patrick?
Just on Steve's point on the revision to the draft terms of reference, is there going to be any wider discussion, or is it just going to be presented to us like 7 days before when you publish the agenda?
Yes, they'll still come back in draft, Councillor. So they have been discussed as part of the development work we've done with members, but mindful that not everybody was able to attend those. So we'll make sure we recirculate them in advance for further comments, and then they're still coming as draft for further discussion within the board. So they're not a done deal when they come back in January.
Thank you very much.
You need to work out how you do your annual reports.
It's actually done. I finished it this week. Well, someone finished it for me. So yes, so it's not hot off the press yet, but it's going through the press. So by the time we come to January, yes, we'll be able to present the report and an associated presentation as well. Very exciting to present it to you.
And I think what we ought to do is make sure that all councillors know that that's happening then, so that at least they can see the report. And Under Lumley wants to come and share the city brand story with us. And I think that'll be good because we're talking about how do we attract people into the city that are those professionals that we desperately need. And I think that would be a good, we can pin her down on that and say what you're doing extra for the health side of things. And obviously on adult social care, we'd be wanting to make sure that the story is going out to attract people here. So thank you. Is there anything else anybody wants to add? Jemima?
Yeah, I have mentioned a couple of times, I really would like to get something around culture in the city into the well-being space, and the Box's first 5 years impact report, which came out on Monday, talks about the health and well-being benefits that have flowed from the Box existing. So I wonder if we can work that into the work programme somehow, just how culture contributes to people. We know it does, but I think it would be good to bring it here, not just talk about it in scrutiny where culture sits, but to bring it here. And another thing, just again, going back to, I referenced that I'd been to Alcoholics Anonymous, whether we could somehow find a way of having a slot for some of our VCS organisations that support out in the community that maybe not. I know Alcoholics Anonymous exists, but I didn't really know much about their work, and they reached out to me and said, would I like to come and see a meeting in progress, which I did, which was very interesting. And I was surprised at the number of the number of people that they work with in the city. So I don't know, just that's something to think about, whether we could have a regular slot, a short slot, from some of the people that work in our communities supporting people health and wellbeing wise.
Rob, that would be quite a good area as far as you're concerned there, wouldn't it, to get some.
Yeah, I mean, the voluntary sector is just huge. And there's so many organisations I'm just not aware of and constantly unearthing. In terms of the work that between the wellbeing hubs and POP, we've got a fair degree of coverage, but I'm aware there are just a plethora of organisations, national, regional and local, operating in the area. But yeah, I'm happy to discuss how we could identify and bring some appropriate people who are doing some very topical and appropriate work to the table to share.
Yeah, I mean, yesterday when we had that session about ageing well, I mean, just the hearing of some of the other organisations that I didn't know of, I must admit. So it would be, I think, if we probably don't want somebody from everything coming, but it might be good to have a catalogue of organisations and what they do, so that we are aware of it. But if we can work on that, whether it comes to the January one or whether it may be sort of the later one, but let's
If we could link it thematically to whatever was on the agenda to make it relevant, to give that different perspective, that would be really helpful.
Excellent.
And just to the point, Jemima, about culture, there is an emerging creative wellbeing development group with the wellbeing hubs, and we've uncovered some amazing pioneering work in West Yorkshire that we're looking to learn from. So that might be something actually to bring forward.
Yeah, that would be really welcome, wouldn't it? Excellent. Okay. I mean, obviously the doors are open for items to come if, we're looking at the well-being of the city. So always happy to hear that. So does that bring us to the end? Right. Well, thank you very much indeed for attending. Those of you online as well, great. It was good to see you, and thank you, Ian, for stepping in for Michelle. Always welcome. And I'll close the meeting. Thank you, folks.
Thank you, Chair.
Thanks, Chair.